Um, I don't know. This is really a very intimate group. We ought to get up here a little closer. So this is me. I am from, I guess I could stand behind there. No. Just here. Oh yeah. I am a graduate of Pomona. I did a MSA Master's while I was going through because I also did the fellowship. I thought as long as I'm doing this, I'm going to get my money's worth out of it. And at the time, the school paid for my master's if I was a fellow. So I did that too.
You're DVM too? Holy cow.
Yeah.
That's awesome.
So I was a veterinarian first. And then that's a whole story about how I turned.
You're cool.
Yeah.
Awesome.
Yeah, right there. So since '93, I've been teaching counterstrain. I started out working with Dr. Jones. My first exposure to going to a meeting with osteopathic physicians was in Yakima. I went with Dr. Jones, who went and had a course with Murray Black and Larry LaForce. Those of you from Washington might know those names. And I realized, these DOs were pretty nice guys, unlike some of the MDs that I'd worked with when I was on the hospital board. So anyway, I got through and I decided I wanted to go back to school. I pleaded with my wife. It wasn't too hard to plead, but she agreed to let me go back to school. You have a wife, 2 kids, veterinary practice is rolling along, taking care of you, and you say, I'm going to give this up and go do this other stuff. It was a good move. Right now, we live in Lebanon, Oregon. It's about 7 minutes from the school. That's very nice. After being in LA, when you have to drive sometimes 45 minutes to go 2 miles, it's really nice to be that close. And I do some woodworking in my shop. No conflict of interest. These are learning objectives. One of the really kind of tricky things that happens when we talk about this is that we forget that there's 2 different types of lymphatic vessels. There's intrinsic and extrinsic. And they're kind of contrary in the way the name is, because if they're intrinsic, where they are is they're with that pumping mechanism is within the muscular system. So if they're doing that, if they're extrinsic lymphatic vessels, which are the ones out in the fascial tissue, those are your extrinsic ones because they have to pump with an intrinsic mechanism. Does that make sense? Didn't to me when I first heard it, but that's the way they do it. Now, one of the things that's really interesting is how lymphatics function, and now they kind of tease me about being the lymphatic guy because I really think that we've missed the boat by not looking at these things appropriately. I think a lot of times what we do is treating lymphatics, but we don't know it. If you can know what you're going to do, that gives you a whole lot more power on how you're going to do it, and you can do your work purposefully. Chapman's reflex points, we all were taught those. Whether or not you believed in them or not, that was another story. But I think in hindsight, if we can take Chapman's reflex point and recognize that they really are a visceral manifestation or a somatic manifestation of a visceral problem. Because what's happening is that increased sympathetic tone that's coming from that visceral structure is going up into the spine, and it's at the spinal level, so it's a visceral somatic reflex. If you want to just do your anatomy, you can find them. And what we want to do is treat that musculoskeletal component, or we treat the viscera, and it allows us to do the other. Now, with the regular lymphatic tissue that we're talking about, it's more of a somatosomatic kind of a dysfunction. So you may have a musculoskeletal problem that's causing this lymphatic dysfunction. But you can treat them either way. And instead of treating them with little circles like we used to do with the Chapman's points, if you do just a fascial glide through the direction of the lymphatic vessel, you can actually activate the lymphatics, which is what's kind of fun. So I want to make sure we differentiate between the musculoskeletal tender point, which is what we do with counterstrain, and the lymphatic tender point, which is what we're talking about today, which is also like a Chapman's point. They used to call them Jericho spots. There's several other variations of how they named those things and how they work. All right, so we did that, we did this, and we're down there, okay. So the basics of counterstrain, you all remember that? You find a point, you find a position of comfort, you use it 2/3 better, You hold it for the appropriate amount of time. You're going to monitor it, but not squish it while you're monitoring. One of the things that beginners always do is they just keep drilling that point while they're waiting for it to go away, and it doesn't go away. Slowly return to neutral and recheck. So with the reason we call this lymphatic counterstrain is that we do all of these things. Now we find the point, that's true, and then the next thing we're going to do is figure out what we're going to do to make it comfortable, which usually includes a fascial glide, and that's a little stretching of the tissues, and we'll talk about why that happens in a minute. Is it better? Now the thing about these guys is they're almost always 100% better. I mean, and it happens within 10 or 15 seconds, and it's quick. Is it better? Yeah. With monitor, you want to do that still. Now, if you push on it too hard, you're not going to allow the lymphatics to start pumping. So you got to just be gentle with it while you're listening. Put it back into its comfortable or neutral position and recheck. So it's all pretty much the same. Early on in my career, Dr. Jones told me that if I have somebody that has headaches, at least 50% of them are going to have a first rib problem. So I thought, I was always kind of contrary. So I thought, okay, I'm gonna find out if that's really true. And I found out that's absolutely true. If you find somebody has a headache, if you haven't treated the first rib on that side, especially if they're unilateral headaches, you're missing the boat big time. Because think about, this takes us back to, where's the sympathetics? T1 through 4. And they're going to come right up into the head. And so if we don't clear those, you're not going to lower your sympathetic tone, which is not going to lower the tension going into the muscles, which also will not allow you to treat your lymphatics. All right. So anyway, I looked. Now I found also that the upper ribs could cause a problem. And like I say here, we had to really add the top 4 thoracics as well. So you'll find all of those issues with what we're doing. So 90% of all the headaches kind of fall under a few categories. The biggest one is almost always migraine. Now, as PM&R docs, you do get referred the tough patients, right? That's pretty much, if I can't fix it, then I'm going to send it to somebody else. This guy here is probably way, way overdiagnosed. And the reason for that is that the primary care doctor, or sometimes even the neurologist, can't treat it. Or what they do for it doesn't work. And the injections don't work, and the drugs don't work, and all that stuff. And so then they move on to somebody else. What I'm here to say is that most of the headaches are going to be tension headaches. You can have some cluster headaches, which I still think are probably tied to the same kind of a problem. And then you have your chronic daily headache, which absolutely is lymphatic. And these episodic type headaches, our most frequent headache is just the muscle tension headache. And if you can get in there and treat that guy, you're going to be good. Let's see, did I go past 2? So most common findings in a muscle tension headache, the upper ribs and thoracics. You got to clear those before you go after the rest of them. It's just, you have to. Cervical intervertebral dysfunction, cranial dysfunction, absolutely. And then the bottom one is the one that took me longer to learn than I should have, but is your sacral dysfunction. With the discovery, and I was in school when they did this, the myodural bridge, are y'all familiar with that? Which is the little muscles that go between C2, C3, go from the backside through between the vertebrae and attach to the dura. When the sacrum gets stuck, those start to tighten up and pull. And what that'll do is end up with a dysfunction that doesn't really have a lot of tender points in it, but it's stiff. You'll find the opposite side of the neck almost always. You can treat that. And that looks really good, and it's nice, and you feel good about it, and the counterstrain points are gone, but on the left side, it's still stuck. So you go down, and you have to look at the SI joint. You'll either find an upper pole or a lower pole, and whether you want to talk about Van Buskirk's way of doing it or Jones, you still need to treat those out. Now, I like to do the little whoop-de-whoop thing, which is a still technique that you can use on the SI joint. Lower poles, you go in and down and out. The upper pole, you go up and around. And we'll demonstrate that as we go through this. So let's talk about the wiring and how it works. That was always my thing, that I had to have a why. Your sympathetic innervation to the ribs, cervicals, always come out of the upper thoracic segments. Pain, increased sympathetic tone, increased muscle tension, increased firing of the gamma motor neurons. That's just what we work on as osteopathic physicians. Now, long term, what happens with the chronic stimulation? We're going to see changes in the spinal cord fluid mix. You increase the amount of glutamates. Now what that does is it starts to reduce the functionality of the little internuncial or interneuron, the one that inhibits the primary nociceptor. If we get enough glutamate in there, you're going to have enough calcium then influxes into that little interneuron, and it'll kill it. And so in those situations are your patients that you'll end up with that are chronic pain. Then there's just not a whole lot of stuff you can do for those guys. There's some work coming out of the European studies and some of that where they're looking at regenerating or actually injecting stem cells into these areas to see if they can get these guys to come back. I've seen one patient that was a spinal cord fracture and had a bunch of injuries, and they did that with them, and they did pretty well. But that's one out of I don't know how many. All right, so how does it work? So we get injury, pain, tenderness, increases the sympathetic tone. We go down here. This leads to lymphatic stasis. This is where the kicker is. The lymphatic stasis comes from overstimulation with your sympathetic nerves, which come from nociception. What happens if I give too much sympathetic tone, and you like to use the heart for an example, too much sympathetic tone, boom, 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 and it starts going faster and faster and faster. We end up with, and this is where the students all go, yeah, cardiac fibrillation or atrial fibrillation, AFib. Now, when that happens, we don't have any pumping. The lymphatics do the same thing. They get overstimulated and they don't pump. And then we end up with areas of lymphedema around that, in that specific area. Now, it was a time when we just thought about it as a Chapman's reflex point, because that's really the same thing. You've got the lymphatic fluid in there. And what we need to do is get rid of that so that the body can work. So this gives us localized tenderness, that lymphatic tender point. If we do traction over the valves, and this is the fun part, if you're a mechanic or you've always liked to do hands-on stuff, this little lymphatic vessel has a lining in it, endothelium. The endothelial nitrous oxide synthase enzyme activates when you traction over the top of the lymph vessel. And as soon as that happens, it causes vasodilation. As soon as you get vasodilation, you get the spontaneous contraction, just like you would when you're looking at the atria, and it starts pumping. And it starts pumping in 10 or 15 seconds. I don't think, hold a lymphatic tender point more than 20 or 30 seconds, and it's gone. So I can treat much more quickly than I used to do with counter strain on all other points. The other thing is, with this, you're going to find that that counter strain point that you know you had them in the right position, and the darn thing just would not turn off, most likely it was this. And so if you add just a little fascial glide to it, then you go, duh, and you fix it. All right, so this results then in relaxation, stretching, and so forth. I go through that. All right, this is kind of fun if I can get it to work. There you go. I like to show this to the students because this is a lymphatic vessel, little lymphangion. Some of the stuff that I was taught when we went through medical school, some of the things we did to get that lymphatics going, it was messing with those guys. I mean, it was traumatic for them because they're just really tiny, almost a web-like structure. So we don't want to do that much. Now, this one's kind of cool because this is a little lymphatic vessel. This is at Texas A&M where they're going to stretch this guy, and then they're going to let it go. And it takes a little bit of time for it to start pumping, but they're going to do one more stretch. This Geshev guy, he's pretty amazing. Another little stretch. And here it goes. It's going to start in just a second. Well, not a second, but there it goes. And now as long as it's pumping, if the fluid is there for it to pull into the inside of the vessel, it continues to pump. When you get you're working on a foot, and you get the whole foot pumping together because nitrous oxide, and they all kind of get coordinated, you'll get to where you almost feel what the cranial rhythm would be, because you're going to have that whoosh, whoosh, and it just pulls it out. Yeah?
How is this visualized? How is this captured?
Electron microscopy. You see, that's the thing about lymphatics. They're tiny little suckers. They're little bitty guys, and we couldn't see them. So for a long time, we just really how do I say this, disrespected them. Because when we look at all of the places that lymphatics are in our body, which is everywhere, we didn't know they were there, and we just went happily along. However, if we start to recognize what they're doing and how they're doing it, that's pretty cool. Oh, I like to stick this one in because it's a picture of a little lymphangion. There was that Battlestar Galactica way back when we were kids. This is the way the spaceship looked. So it really, that's the only reason I have it in here, because it gives us some humor as we work our way through. Okay, so the lymphatic tender point are areas of coalesced interstitial fluid. Dr. Redding used to harass me about these things and said, well, how can you can't draw fluid out of them. You can't stick a needle in it. And I said, well, that's true. And you couldn't do that with Chapman's points either. And when you stick a needle in it, it's just fluid, so it just goes somewhere. And it really isn't labeled, except maybe you'll have some substance P increase and maybe some bradykinins, but it's not going to be anything really significant. These guys are usually no more than 1 centimeter in diameter, maybe a little bit bigger. Depends on how much pain you've got and how long it's been there. Now, the ones that you're going to find where the, levator scap, there's a spot right over the top of the corner of the levator scap. Everybody says, oh, this is a trapezius. This is really bad in here. Or it's a levator scap. Arm up to the side, a little fascial glide, just pulling the arm out, stretching those tissues across there. You're going to activate all those lymphatics in there. It starts pumping. 30, 40 seconds, it's gone. And you're going, where did that go? Because it was really big here, and it was hard. So yeah, first couple of times I was doing this, it was just mind-altering. So your Chapman's points are essentially the same thing. The difference is its origin comes from a visceral structure, which is providing the increased sympathetic tone, which is causing the lymphatic stasis, which results in all the other changes. Now, okay, we'll keep going. Increase. All right, so it is my experience that any inflammatory process which increases sympathetic tone can result in this. Now, is it always going to do it, and is it always going to get stuck? No, because we have a pretty good creation that we've got that we walk around in and we do things with. So that's where the body usually takes care of itself. Once in a while, it needs a little nudge. All right, so occipital headache protocol. One of the things that I've found is that you really, really have to do your MSK points as well as your lymphatic points. If you don't take care of your MSK, you're going to get almost immediate recreation of your lymphatic stuff if you happen to get it gone. So you want to always look for a first rib. That's number one. A lot of times people just go for the head to treat headaches. You really want to treat that first rib. You got to do it. And I'll show you an alternate technique that I kind of created on my own initially with my wife. I call it Barb's shoulder or Barb's rib or whatever. But she came to me one day and said, my hand goes to sleep when I'm driving the car. And I was concerned. It was a new car. So that's a joke, guys. They've heard it already. So anyway, I said, go sit in the car. So she went out, obediently sat in the car until her hand was asleep. And then she came in and laid down on the tea table we had at home. And we fooled around with, because she said when she does this, it gets better. And so I stuck my thumb in there to find a tender point, and she had a really good one on the attachment of the middle scalene. And she brought her arm up here and dropped it, and that thing kind of melted away. So over the years, I've kind of evolved this one, and it works really, really well. I don't think any of the first rib techniques work as well as this one. That's my bias, and of course, I've indoctrinated these guys. So we'll show you how to do that one. Next thing you're going to look at, if you treat just one end of a muscle, does that tender point come back? Almost always does, because you got to clear that whole muscle. So what we're looking at here is we cleared out the one on the rib. Then we got to go up here because your middle scalene goes all the way up. Now, it's a tricky one because it goes a little bit behind. So we call it a PC3, but it goes behind that. It hooks onto the articular pillar, wraps around the top, and hooks onto the front side of the transverse process. So when you want to treat that one, you actually go forward. And this is one of the mavericks Jones talks about in his book. If it's a PC3, it actually goes forward bent rather than extension. because all the rest of the cervical vertebrae go in extension, side bend away, rotate away. AC1 is another one that it started out being really simple for me. You just rotate the head away, point right here, that's on the posterior aspect of the ascending ramus of the mandible, and it's pretty easy to treat, yeah? Until you find out that, oh, it doesn't always turn off well there. So then you end up pulling it and rolling, and then you put overtraction, this is Larry's term, overtraction on the top of the head. Oh, and that's actually treating, we didn't realize, but the mastoid lymphatics, which have a tenderness at the same place that the AC1 is. And when we treat that, that also clears the mastoid lymphatics, which drain the external auditory meatus, eustachian tube, and of course, once we get into that, we get into the ethmoid plexus, which is your nasopharyngeal lymphatics, which is where the brain dumps most of its debris as it drains out from the head. So your lymphatics, as they come down, they wrap in and they dump it through that area. In addition to that one, your patients that have TMJ, how many of them are going to have problems with the stylomandibular, stylohyoid, sphenomandibular, those little ligaments / muscles? Those are tricky little guys, because what you find with those, you got a ligament, which is your protection. So it just doesn't go too far, but layered right into that, you've got muscle. Can your muscle have a counterstrain tender point and your ligamentous structure be dysfunctional? Absolutely. How do we fix ligaments? We usually do a ligamentous BLT, a little stretch, balance, release. We can't do that with counterstrain points, so we've got to shorten them up. So a lot of times you're going to find that this one is going to have both, and you'll need to be able to treat those other structures as well. All right, so PR1 is down here, and then we're going to do our PC3. What you see is here. Now, if your PC3 is truly on the spinous process, more so than on the articular pillar, you will go into extension with side bend rotation away. But most of the time, you're going to find your PC3 is going to be right over in this area. Okay, and AC1, we talked about where that is. I don't think I'm going. There we go. This is the first rib technique that Dr. Jones taught. I used it till I got through with medical school, and then I went back to the one that I did myself, and it works way better. So here's the area where your tender point's going to be. Everybody's looking for that tender point through the trapezius, jamming back in here, and it just doesn't work because you've got way too much stuff to get through, and you can't really feel where you're at. So it's going to be right in here. Your trapezius is going to be back here, and you're going to come down on top of that. Again, we'll show you how to do this one. It works really, really well. Yeah. So this is kind of where we're at. Now, my thumb is underneath there in front of the trapezius, but it's down on top of that first rib. My fingers are resting on the clavicle, and the arm comes up over the top and rests in that position. Okay? Now, rib attachments. So if you have this guy that's there, you're saying you have that one. Yes, she does have that one. You have your, this is the middle scalene. Down here is the digitation or the attachment of the serratus anterior superior. So that one is the one that comes from the superior anterior medial corner of the scapula, wraps around through the axilla and attaches up underneath on the first rib. Over here, we've got anterior scalene, and then, of course, we've got the subclavian groove, which is where our vessels go through, where the artery and the artery, vein, nerves, etc. Okay. And I stick this in here for the students because they need reminders of what all these vessels are, where they're going, and why it's important. Also, if you get a shooting response when you put that central line in, you're probably not in the vein, and that's not a good thing. All right, so let's go to the next one. So this is our PC3. I think this was, Dr. Jones did this picture. It's a little bit more forward bending than you need, so you kind of do that by feel. Again, here's your anatomy. Okay, anterior scalene, middle scalene, and this is where it comes up, wraps around, and hooks in there. And that's why that PC3 has to go forward instead of backwards. All right. Nothing like pictures. back here, posterior scalene is kind of a funny one. If you're trying to do a posterior scalene, which is actually a second rib, and you're looking at treating it, everybody thinks that they ought to go forward because in the Philadelphia manual they put down flexion to treat this. It doesn't, because the posterior scalene is going to require you to go into extension so that you can shorten this guy back here. Don't see that one a lot, but if you run into it, that's where if you're having troubles with it, that's where you're going to end up. And this is our middle scalene right in here, and then the anterior scalene's in front. This is the other one I was mentioned to you before about that AC1. The AC1 tender point also, this is one that I kind of stumbled on because I had a patient that I put her in the position, I rotated her head away to turn off AC1, I did the mastoid lymphatic traction. None of it worked. And then I was studying really frustrated one night. My wife would watch TV and I'd look at the anatomy in my computer. Turns out that the autonomic innervation for the posterior aspect of the ascending ramus of the mandible is the same as the stylohyoid muscle. So I thought, well, if this is really counterstrain, I should just shove that stylohyoid muscle over and turn it off. And I did, and it worked. And so now when I work on somebody's head and I come up here to this point where I'm going to be treating an AC1, right away I just ask, do you have TMJ or have temporomandibular joint problems? And if it's an affirmative, then I put them in the position for treating my AC1. Then I slide my fingers underneath and I shorten the stylohyoid. And I get a lot more dramatic impact out of that. So you can kind of see where the muscles are and the ligaments. And if you think about the fact that it's not just a ligament, there's a muscle there with it, then you understand how you have to balance that thing out. All right. Not much different than what we do with cranial work. However, it's a different understanding of what you're doing. And so sometimes the intent makes all the difference in the world. All right, so we talked about that already. AC1, MSK, this is it. Difficult headaches, difficult shoulder pain, difficult ribs, difficult anatomy. One of the problems that we have here is you also have another muscle that can get involved with that first rib dysfunction. And this is one that I worked with Charlie Kaluza. I don't know if anybody is familiar with the Portland area. He's an ENT surgeon down there. He retired secondary rheumatoid arthritis. However, I was working with him as a student, and he knew that I knew counterstrain, which sometimes was a curse, let me tell you. Dr. Rott, who was our board-certified osteopathic physician internist, he had more board certifications than anyone else had had by the age of 27, which was 5. He was very proud of that. He sent this patient over to Dr. Kaluza's office and said, this guy's got a tumor in his neck. It's right there. So Charlie looked at him, and Dr. Kaluza looked at him and tried to do his work and did everything. He says, oh, hell, it's not that. It's something in a muscle. Ed, you take care of it. And he walked out of the room and left me there. And I'm thinking, what the heck is this? Now, Charlie had, instead of regular chairs, he had barber chairs that he used to examine people. So I had to figure out a way to get the barber chair down so I could at least get the patient semi-horizontal so I could get in and find it. What we found out, though, is that this one was an omohyoid. And if you remember where the omohyoid goes, it goes from the hyoid apparatus down, little sling at the bottom of the sternocleidomastoid, slides back and attaches to that little ligament that goes over the top of the suprascapular notch, and that's where that tender point was. So it was buried up underneath the trapezius, and you can see how if somebody was mashing through there, they would think it's a trapezius, and it's not. It's this guy, inferior belly of that. So you have to look at that one and treat that if you've got a problem. So first, ribs that don't go away. First thing you want to look at is then the omohyoid. Next one is going to be your serratus anterior superior. Yeah. So this is my version of a Dr. Geertz, G-O-E-R-T-Z. I tried to figure out who else would, I like to think I'm really smart, but I know I'm not that smart. So I went looking for, did somebody else come up with this before me? 1926, 20-something, there's a guy that wrote an article on first rib treatments, and this is what he did. The guy's name was Garrett, so I thought, well, maybe we're close. But that was, and he did his a little bit more aggressively. He did it rapid fire, which is a little bit like still technique. But anyway, just stick that one in there for fun. The omohyoid, you're going to be able to get him in that first rib position. Then you rotate the head towards, and you use the larynx, and you bring that all the way across, so you're shortening the inferior belly of the omohyoid muscle. Again, another picture. This is the guy right here. You can see where the suprascapular notch, and that's where that guy goes. Superior belly, inferior belly. All right, omohyoid findings. These are going to be things that you'll see with a person that comes in, and you're saying, gosh, what could they have? Recurrent headaches, shoulder pain, impingement they can get, which will actually get your referral down the arm. The impingement usually is because the omohyoid inferior belly is too tight, the shoulder rolls forward, you get impingement with your supraspinatus as it comes up over the side. You can get overlying trapezius pain because the trapezius is overworking, trying to hold it still so it doesn't have pain. You get levator scap pain, and again, it's really not levator scap pain, it's lymphatic dysfunction. You can have some thoracic outlet. With the students, I always pimp them on, well, what part of the hand is numb when they're thinking about carpal tunnel? Is it the thumb? Is it the finger? Is it the whole hand? And obviously, if it's the whole hand, we have to work up here. All right, so we talked about that one. So this is the one supine technique for treating that inferior belly of the omohyoid. All right, okay, same thing now. If you want to do a double, you get to do the first rib and the omohyoid at the same time, which is what I generally will do, and that works really nicely. Dr. Kaluza said ENT surgeons don't treat anything that's below the larynx. So this was his way of treating, and he would go after the superior belly of the omohyoid. We did actually end up writing an article about this. It was translated into German, though, so I never could really read it. The serratus anterior superior, this is that guy right here. You see how it comes around and it hooks on up underneath there. This one is not real common. You'll palpate it by going up into the axilla, way up here, and then you push medially. This one hurts a lot, a lot, a lot, but it really, really relieves a lot. So if you get ambitious and you want to go after that one, just remember that shoulder's got to come up. You're going to be way up in the axilla, and you roll the shoulder up and over. Now, the temptation is to slide the shoulder up while you do that. But if you look at the anatomy, if you slide the shoulder up, that stretches it. So you've got to keep the shoulder here and roll it forward. Yeah. Okay, another picture, same thing. This was my challenge, is I had patients that would come to me, and I did a really nice job of treating everything from here up for headaches. One day I had a patient that came in, she said to me, you know, Dr. Goering, I really like what you do, but you know, if I go to my chiropractor after I see you, my headaches are gone for like 6 or 8 weeks. And of course, what did I think? What the hell is he doing that I'm not doing? So I started trying to figure it out. And then about that time, we heard about this myodural bridge. And then I thought, well, maybe he's doing something down the low back. So I spent a whole session of treatment looking at her low back. And I did all the stuff I could, thinking, oh, there's nothing. Her SIs are compliant, everything's good, but she's still got this other stuff. So then I went up and I treated her top end, and that part on the opposite side, the contralateral dysfunction, it wasn't there. So what I found was, if I correct this, go down here, assess lower pole, upper pole bilaterally, turn off the one that's there, this then relaxes, which is what really does happen. So you'll get that myodural bridge will release, and voila, you're done. It makes a huge difference. Now, one of the things that you'll find that is really common here is people that have a short leg are going to tend to jam up one of their SIs more than the other, and that's going to impact this. So it depends on where your headache's coming from. Very often your headache's going to come from the SI, which is why a lot of the, I will say, I used to be a young person. A lot of the guys that used to be old timers when I was young would say, when you start treatment, you always treat the sacrum first. I don't know if I would, I still don't treat the sacrum first, but I do want to respect it and make sure that I look for it, so that if I have somebody with a headache, I want to be able to do that. So I do what I call still technique, or whoop-de-whoop is what I called it initially. I figured it out on my own. Then I found out Van Buskirk has a whole protocol that he does when he treats this thing. But I still kind of like the whoop-de-whoop comment, and the students seem to think that that's pretty cool too. So that's where we are. So this is what we talk about. I think you guys will have a copy of this thing, so you can come back and look through this. It's the SI motion that doesn't occur, and as soon as that gets trapped, then that motion, that lack of motion, is conveyed all the way up to the spinal area and the cervical spine, and you're going to have that C2, C3 that isn't especially painful, it's just stuck. All right, same thing. Okay, so that shows you that this is connected to this, which is connected to this. It wasn't until the last little bit that I've actually seen in the cranial literature where we've talked about the C2, C3 and recognized that it really is the myodural bridge that's causing that congestion in that area. So you know who was the one that discovered that myodural bridge? You guys do, because you've heard this already. It was a PA student that was doing an anatomy course in Pennsylvania, and he was going through and he said to his professor, "What is this muscle stuff in here?" Wrote an article on it. Nobody believed him to start with. They did a couple more. They've done research now, and they've shown that actually is there, and that's just part of our problem. One of the things that happens as we go along in medicine is we get to where we can look at little things better, and this is one of those things. So standing or seated flexion test, you can do that. You can also look for just the compliance. I usually just slide underneath there, check my tender point for the lower pole and the upper pole, treat that one, but I treat it with still technique, and off I go. It works really quickly and it's fast. All right, and that walks you through the whole treatment protocol if you want to go through and review it. All right, so yeah. Now, headache myths, what we're going to talk about. Sinus headaches turn out to have migraines. That isn't really the truth. Matter of fact, they went through and they looked at people with quote-unquote sinus headaches, and they found out that most of them didn't have sinus headaches. We also looked at people who have eye strain as part of their headaches, and that probably isn't true either, unless maybe they're doing a lot of other stuff, but most of the time not. Yeah, the headache correcting vision may improve some of the headache symptoms in some patients, but it's not really the primary thing. We used to think that hypertension is the cause of headaches, and hypertension really is not the cause of headaches. They've done studies where they've looked at people, and the ones that have headaches don't especially, unless it's one of those headaches where you've got a blood pressure of 220 over 160. Then yeah, we're going to talk about that. But if their blood pressure is within a relatively normal range, then you're probably not going to find that, because when we looked here, the physicians aged 40 to 84, they found out that there really wasn't a relationship there. Now, what we're going to look at here is kind of a fun thing, because we're going to look at these structures here. So if you see in this guy, there's a little canal there, and out of that comes, they've got the occipital nerve, and then you can see the artery. They don't put the vein in there, and they absolutely don't put the lymphatics in there. So let's pretend that we had those in there, over here on this side as well. Now let's say that I get some muscle pain, muscle tension, and that causes increased sympathetic tone to my lymphatic vessel that's trapped within this little canal. And I get my lymphedema. That lymphedema then is going to result in the nerve being pushed over next to the artery, and the artery is going to go boom, 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 and you'll get that pain that radiates right over the top of the head into the forehead. So this is your occipital nerve, and we're going to call that our occipital headache. That one we treat by applying a gentle traction on this side. We'll grab the parotid gland, pull it forward and up towards the eye, which actually stretches all of these guys. And within 10, 15 seconds, the acute tenderness that was there before is gone. I hate to admit that a lot of patients that I had, I would treat and really treat and work on them. And finally, I would give up and I would inject this with my steroid mix and hope that they made it home before the headache came back or the lidocaine/bupivacaine wore off, because it would wear off, and of course they're going to have their headache, and you tell them it'll take a couple days for the steroids to kick in, and then it'll get better. If you do this little treatment that I show you and then teach them how to do it for themselves, it's gone, and they can treat it themselves, and you don't have to worry about all of the other complications you get into with doing injections in the site. Several of the students that we've had come through, some of them have even been using Botox quite a bit, and they don't anymore, and they don't have their headaches. They get them intermittently, but not anything like they had before. So if it works like that there, why doesn't it work like that everywhere? And that's what it does. It does work like that everywhere, which is really cool. You've got area down under here, which is our thoracic duct, right? Because it comes up and dumps into this area. So you treat this area right underneath here, and you're going to find you can open that. If you want to look at the right side, it's the lymphatic duct. All of those things you were taught about what the order of treatment is still true. That part's good, but we just need to know how to do it. All right, so this is some of the history that we have within our profession. Still was a big advocate of doing lymphatic stuff. We also spread this concept into the European model, and there was a Dr. Danish, a guy named Emil Vader, there was a Castillo, Ferris Swift. All of these osteopathic physicians would treat lymphatics. So the unappreciated culprit, to drain the cervical lymphatics, and this is what I read for Dr. Millard Fillmore. He wrote this up, and he said that to treat somebody shouldn't take more than 10 minutes. You got to be done. And that's about what it takes if we do our lymphatic treatments now. And it's extremely effective. Yeah, so this is there. Okay. Chapman, we talked about that one before. So how does it work? We got our lymphatic structure, the lymphangions, the pumping. Again, just this is a review now of how do you do it. Now, innervation of the lymphatic vessels. There's really little bit of documentation. We know that the only parasympathetic innervation is probably in the thoracic duct. Otherwise, there's none. Yep, okay. Trauma will reduce the function of the lymphatic components to remove the fluid. One of the things that I tried to figure out, Frank Willard, are you guys familiar with Frank, who is the anatomy guy out of Maine? And I asked him one day, I said, so how come this does this? How come does the fluid get all tightened up and the ankle gets swollen, and how come? Well, he says, you know, if you sprain your ankle while you're running away from a lion and it goes flop, 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 flop like that, you can't run very fast and the lion's going to eat you. And if it swells up really tight and you can run, then you can outrun the lion or the bear and he's not going to eat you. So it's a survival thing. What happens with, and I can show you, I've got some beautiful slides that show us treating a young man that had sprained his ankle. It was huge, and in less than 48 hours, we had it down to almost nothing. He's healing up, and this guy had a severe ankle sprain. 2 weeks later, I treated it a couple times, and then we taught his wife how to treat it. He was in Costa Rica hiking in the mountains, less than 2 weeks, 10 days. So that was Trevor. Okay, so we talked about that already, and we talked about this. And this is kind of a rehash of the same thing. So let's go to work. Yeah, pretty cool. All right, we talked about these already. We're going to go through that. Okay, so if we want a break, we can do that now, or we can start doing treatments. Yes, sir?
So your treatment of the first rib is different than Jones's treatment of the first rib, because he used to be a
Yep.
hanging arm.
Yeah.
And it was hard on my back.
Yep. Well, that's the thing. I'll show you how this one works, and quite frankly, I would never do it another way.
Yeah, I stopped doing it because it was too hard on me.
Yeah, I agree. That this one where you do the arm up over the top, yeah. I knew it was good when I went and I taught some of the students from another school how to do it at convocation. And then the next year I went back and there were students teaching other students how to do that same technique that I didn't know anything about. So it's been, I think it's pretty well out there in the profession now, and so a lot of people are using that instead of. So, what's that? So we can, she's anxious. So do we want to do a break or do we want to just go right on into it? Break? Let's do that. Yeah, bio break. 5 minutes.
Interesting how you sometimes do second. I find I always start, 90% of the time I always start the second first. Because my results are better.
Yeah.
And then
Glide up this way. Now, Jones had this one as an anterior-auricular and a posterior-auricular. Fascial glide's the same, treatment's the same. How's this now? Gone?
Mostly, yeah.
All right.
A little persistent body.
All right. How about now? Still there?
Better.
Okay. One of the things I try and impress with the students is that don't think that just because you've done it a few times, you may not have to do it more than once, because he's not done it more than once. So you might not capture all the lymphatics that are in that area that need the traction. Pretty good there now.
You can see he has some blanching of his finger, so he's down to that fascial layer. That frontal
yeah.
temporal fascia is pretty thick there, so he has a good grip of that fascia before he's pulling to the vertex.
This is what Jones would document that he had to do on some of those to get his AC1 to turn off. But the reality of this is the lymphatic for our mastoid lymphatics, which are here, but they also drain into the nasopharyngeal plexus. Now we can imagine if somebody has a whiplash or somebody has shoulder, head, neck pain, how that lymphatic stuff is going to involve your ethmoid plexus. And if it's involved, you're not going to get good drainage from the brain, and you end up with the one article I saw, the most recent one was, well, not most recent, but the one that was published a year ago, January, not this January, but a year ago, from Korea, and they talked about the brain drain, and they were able to document and visualize the drainage from the brain into the nasopharyngeal region. All of the lymphatic fluid is going through that area as it goes out of back into the body. Oh, you're stuck right there too. This isn't tender though, yeah?
A little bit.
Yeah. But this is way better, yeah?
Yes, it is.
So that's pretty much what you would do. Now, he does have this guy over here, and his is more of a 2-3. So if somebody wants to hold his neck, yeah, just grab a hold there, and you'll feel that just there's a tension on his left side.
C2?
C2, C3, right up the top.
So this is that myodura bridge he was talking
Yep.
about. So he's going to treat the sacrum.
So now we're going to come under here. Let me get around his belt now. Is this the one that's tender? Or is it this one? This one down here. Yep, so it's lower pole. So my version of how this works is a little different than what the other guys do, but that's kind of what we do. We bring him up, and I want to, what's that? It's already changed. Most of what I want to do is just loosen this up first before I do my whoop-de-whoop. So push gently, knee into my hand, 2, 3, 4, 5, and then relax. We'll go a little bit more. One more push, 2, 3, good, and relax. And we'll come over here, push back towards me, 2, 3, 4, 5, good, and relax. Now gently pull your knee towards your right shoulder.
See how he has his arm under with the knee
And
being
relax,
held into
good.
that external rotation of the femur?
This ought to be pretty good now, yeah? So lower pole, we start out here, and we work a little grind, and then we want to come inside, down, out. And that should be pretty much gone. And that should be pretty much gone.
Release. The last movement, release.
Yep. So what we did is we reset the SI joint. Once it slides back into the neutral portion, it starts to move, and this response is almost immediate. I like to do this before I even try to approach the head, because this lets the head work. And if you've got your sacrum rocking with the base of the head rocking, then when you go to the head and you go to look for what you want to treat, it's really something that's there. It's not something that's compensating for something else, which is getting in the way.
So pair up and do the MSK portion?
Yeah. Yeah, good. Grab a student and they'll help you. You want to do it or do you want to have it done?
So there's 4 10 minutes plus a bit. Do you want a student?
He's all
to
done.
focus on?
Namaste.
Namaste.
Small enough number we can trade off.
Oh, sure.
Treat it and then-
Sure. You absolutely.
So that's one of the joys about coming to an hospital course. They get treated once a year.
All right.
Thank you, my friend.
You bet. I feel.
Great.
Isn't that weird?
Yeah. Well, it's also great too because I haven't had anybody touch me down there for a long time that said said woohoo or whatever. So.
Oh, whoop-de-whoop, yeah.
This is just mostly the MSK component, and then we'll pull in the lymphatic soon. Yeah.
Because somebody else lie down there.
I'll lay down.
Okay.
I'll be.
Okay. So you want to treat him? Get him on the table. Oh, other end. Sorry. I always start at the top.
Yeah, that's all right.
Okay. There we go. Let's see. Which one is yours? I think that's the one.
Probably got a lot of.
Yeah, this is worse than the other side, yeah?
Yeah.
Right there. So we're going to roll the head over here. Can I have your right hand? So we bring that up around, drop it on my arm. Now, I use this as my fulcrum. So I pull on the clavicle, pull on the sternum, and you just drop your arm again. There we go. And we go in here, and that should be pretty much gone. Yeah?
Yeah, I mean 90%.
Okay.
Still it's in there.
All right, let's do this. There we. Is it tender back in here?
No,
No, it's still up here.
something just articulated. There,
Oh,
so-
okay. So this should be pretty much gone now.
gone now.
Yeah.
So that's very interesting. That's much easier than draping the arm over the
Oh,
shoulders
God.
and the legs up on the
Oh,
table.
yeah.
And,
Now this is a piece of cake. And that's why I do this one. And when I do it with patients, I'll start out here because most of the time the SI joint only has 1 or 2 problems.
yeah. Interesting. I have patients. Occasionally we'll have ridiculous symptoms, and they'll tell me the only thing that takes my symptoms away is when I do this.
Yep,
like-
that was my wife.
What did she have? What did you find in hers?
Her hand would sleep. I mean, she
No,
had
I mean,
thoracic outlet.
Oh, okay.
Yeah, it was thoracic
And
outlet.
so you released what for her?
The scalings.
Oh, okay.
And what happens when that scaling releases, the rib slides back down into where it belongs. And then all this tension in here is out. Because your arm's up, we're still holding and have that middle scaling released.
Right.
Now, when I bring it back down, so I'm going to swing across, drop it down, put it away, and let that go.
Right.
And then we come back in and recheck, and that's way better. Not all the way yet, because what we've got hiding is this guy right here. So that one we need to move forward, side bend, rotate away, and that's our C3. Gone?
Yeah, mostly.
Oh, we'll go a little further.
Sore to begin with, so.
How about now?
When you put your feet, it's not sore at all.
Okay. There we go.
Now tell me about the lymphatic traction thing you were talking about.
Okay, that's going to be the whole next section.
Oh, okay.
So we want to make sure that we've treated MSK, because if you have an MSK point that's still there, that one's going to maintain that subclinical sympathetic tone, which just shuts your lymphatics back off again. So if you do the lymphatics alone without doing MSK, you'll get mixed results.
Got it.
Ah, there we go. Nice motion. Yeah, that's all gone now. So we're going to bring you back, and that's much better. Is this one there?
Yep.
Okay, do you have TMJ stuff?
No.
Okay. So then we want to just rotate you away. This is Larry's treatment. Finger in front, finger in
My T2 just articulated.
Is that still tender?
No.
Okay, then we're done. Now, if I were going to do the lymphatic, if I found this one, then I would put a finger in front and a finger behind. And Larry described this as overpressure coming down over the top.
Yeah.
And he would use that to treat this, which I'm sure now what he was doing is treating more than just the basics that he was talking about. And
I don't remember him. I remember. I always thought it was he was forcing
the rotation.
rotation.
I
by
know.
doing that.
I know. And that's what I thought too.
And I only had 20 hours with him, so you had years with him.
Yeah. There we go. Yeah, much better. So if you had a person that was doing this, and we turned out that he did have TMJ, and this still didn't go away, you slide up under here, and use your finger right on the side of the larynx. Here we go. And just bring it over, and that'll turn this off.
Oh, interesting.
And you can put a little bit more this way or that, but that turns this guy off. And that's going to be your, I think it's the stylomandibular. Or the stylohyoid, actually. But the stylohyoid and the stylomandibular still hook onto the styloid process, so if one's dysfunctional, it'll affect the other. There we go.
I have not done that. I will definitely start using that.
Now, if you have somebody who has an omohyoid, that's going to be where this guy is down under here. So what I do, have your right arm again, bring this across, drop it down. Now, the tender point would be back in here. Now, what I want to do first is I'm going to rotate away, side bend towards, and then rotate towards. And if that doesn't turn this thing off, then I just use this and bring everything over, and that'll get it. And that's your omohyoid treatment with the first strip. Yeah, there it goes. Yeah. Then we bring back. Be still, don't help me. Doctors are the worst, you know.
No. I was just thinking, first and second ribs are always really tough.
Oh, this will make that piece of cake.
That's good. I used to do high velocity on them. I used to do
Oh,
and
Lord,
then I
yes.
stopped doing high velocity because
Well, it hurts your hands. At least it does mine. So we come in here. And this is pretty good. It's still tight in there. And you're not bad on this side, but yours is still stuck right there. So, any tenderness up here?
Yep.
Yep. Not so much down here?
No.
All right. That's it then. So this is an upper pole. So with that one, we come up, go a little bit over here, and then back here. Over here, it should be a little bit better.
Yeah.
Okay. Gentle push into my shoulder. 2, 4, 5, and relax. Good. One more push. 2. Good, and relax. A little stretch. Go back over here. Push back towards me. 4, 5. Good, and relax. Make this across. Take your knee to your left shoulder. Good, and relax. Well, this should be just about gone.
A little tender, but not. It wasn't bad to start with.
So then we come up, and because it's an upper pole, so the lower pole, remember, we went in this way and came down. The upper pole, you want to go this way and come down. So we rock it here. And when you get ready to, just before you get ready to whoop it out there, internally rotate the foot.
Internally rotate the foot.
Because if you have it externally rotated, all the force goes into the hip socket.
Okay.
And then we come back up here and reassess our work. Oh, that's pretty darn good, yeah.
There you go. Well, thank you.
So in order to learn it and take it home, you have to practice on somebody. So you're more than welcome to practice on me. Well, Dr. Goering.
I'll get out of the way.
will train with other tables.
Sure. How you feel?
Pretty good. I've had some major sinus stuff in the last month or so, worse on the right and left too. I wonder if that was related.
Because that,
And they haven't gotten down to the sacrum yet, Dr. Goering. So
okay.
that happens.
Oh, I'm on. Doesn't matter. Doing? How's he doing? Okay. Oh, he's got a combo of everything, doesn't he? You got it off? Good. Good. Yeah. She's received a lot of treatments, yes. But this again was one of my patients that had chronic daily headaches that had. What's that?
So at my school, they taught us thoracic roll, and they're never comfortable with someone's head in my chest. So I always figured out other ways to get in the first row.
Oh.
I'm just gonna warm up this joint before I bring it down.
So which school?
Des Moines.
Des Moines. Yeah, okay. Dr. Mintiers talked about that.
How's this?
Dr. Goering,
Yes.
you can demonstrate
Oh.
how you traction across the board.
Okay. So your thumb should be the monitoring,
Yeah.
and your fingers are up here.
Oh,
Yeah, just like that. Fingers are on the clavicle,
Got it.
thumbs on that. So then your arm comes and rests here, and then you can use your arm to tug up this way. there.
Oh, yeah.
Uh-huh.
Oh,
And
yeah,
then you
that's
can
no
push
problem.
on here to pull this way. And now you got her all stretched out.
You're fine. And then, once you feel comfortable, you're in a good spot, then you monitor the pulse.
Yeah, just go down here and relax it.
As a,
So you don't need to tug anymore.
as a means
Okay.
of like, knowing when your treatment modality is done.
Yeah.
So you monitor the pulse and you monitor here.
Okay.
Dr. Goering,
So I actually had T-port
isn't shutting off, and I did a first rib omohyoid. I haven't checked the anterior scaling.
Oh, she's having stubborn, huh?
So I'm from the T-Porton area.
Uh-huh. I remember Dr. T. Porton. I had some discussions with him. Pretty good here. Is this still tender?
It's tender there, but it feels like it's even.
Yeah, it was pretty even, but this is where you're at right
Yeah,
there.
yeah, exactly.
So she may be one that doesn't want to do the first rib while she's doing her omohyoid. So this is one where you're going to side bend it towards, then rotate it. There it goes over. And then we're just going to grab this guy and bring it over like so. How's that now?
Yeah, it's not as tender.
Oh, what are you doing?
We're doing just the omohyoid. And that should be pretty good now.
Yeah, that's pretty good.
And you're doing a little bit of lymphatic traction.
No, just
Oh, that's how you're holding it.
just holding it this way.
Yeah, he's just bracing it.
Yeah, just bringing the trachea and everybody all the way over towards it. When it was back underneath, the place where she had the most tension was right on that ligament that goes across. You probably palpated that. But this should be pretty good.
Yeah, it feels much better now. Yeah, one of the guys that works on me, he'll grab my hyoid and adjust it when it's really nasty.
Uh-huh. I've had some guys do that. It doesn't work as well as this.
No, I like more gentle approaches.
There we go. There we go. And again, you follow it too. If it softens and relaxes, I just get further into it. Did she have anything like that serratus anterior?
I didn't check the serratus anterior.
Okay,
That was
well,
gonna
we
be
won't
my
do that.
last approach.
Yeah, we won't do that unless we need it.
Yeah.
But I can poke it for her if she'd like. You bring this back. Good. There you go.
Yeah, that's better now. Yeah.
So, I'll borrow a chair here. I'll just come over here so you can. So, this is one of those. I apologize. This might be painful. We come way up here, and where we're going is all the way. I'm going to rest that right on there. Grab this, bring it down, go way up here.
It is tender, yes.
Okay. So, we're going to bring this down. I'm going to roll you up. And we get this arm right here. And so you got to keep it down, bring it across. How are we doing now?
Feels good.
There it goes. There we go. Ah, there we go. And it just released. So whatever's pulling it the other direction, let go so we can do this. Way better?
I just feel like more of my sinus is draining,
Ah,
which is good.
yeah.
Back in my throat is safe.
Uh-huh. But this isn't hurting as much now. Okay.
I took a Celebrex this morning, so I'm not in as much pain as I usually am. So I'm usually really in a lot of pain on the coast. So.
Ah. So where are you at now?
Arizona?
Arizona, okay. That's the nice warm place.
Exactly.
Yeah.
So this is all good new stuff to learn because I enjoy teaching and learning.
Mm-hmm. Now we bring this back down nice and slow. And when I stick my finger way up there, not much.
That's pretty good.
Okay.
Thank you.
Okay.
So now I know what you're talking about when you're doing that. So I'm getting a smattering of people in Ahmed that are spraining their shoulders, ending up with the ulnar neuropathies going through. And I'm like, their EMGs are coming up okay.
So a lot of them have this pain that's going to be right in here.
Yeah, some of them are getting the epicondylar
Like,
blockage
well,
of the
or
ulnar
the-
nerve, but a lot of them are still thoracic outlet,
Okay.
or maybe somewhere impingement.
Anytime I get this on top, I
Yeah.
do the subscap.
Okay.
Just, my,
Okay.
my students get fed up with it, but that's, because anything up here,
Uh-huh.
these three muscles are all fighting with one muscle.
Right.
And so, in the subscap, we're going to come in, we slide up, go up against the rib, and then come down. Oh, you've got one.
Yeah.
Scooch towards me a little bit. So again, we're in here, drop down, there it is.
Yep.
So we bring the arm down.
I never thought of that approach there because I
I
just
do.
inject it the other way.
So if you get to do this, you'll have a lot more fun.
Okay.
Just now, I do extension. I like a little traction and internal rotation. So we're doing a combination of latissimus at the same time we're doing.
Okay. And that would probably cover a lot of people.
Oh yeah, almost everybody that has supraspinatus impingement, I do this with, and it's boom, knocks
That
it
is-
right
I
out.
feel the whole thing coming from the front
Uh-huh.
too now. So it's releasing back there and it's releasing back there.
Yeah,
Yeah.
great fun.
Yeah, that's very cool.
Yeah, see there?
Uh-huh. Wow. Okay.
Yeah. And you can, if you have to, you can do this one seated, but they tend to lean on you like that if you do that. But this works well. There we go. There we
Yeah,
go.
I definitely got some people I can do this on.
Oh, there's our pulse.
Was my pulse gone for a while?
Well,
Then it came back, or-
there was no pulse in your subscap.
Oh, got it.
And when we get this down and it finally releases, I got a nice boom, 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 nice therapeutic pulse. Yeah, it's pretty much there.
Cool.
And let me check. A lot better?
Oh, yeah.
Okay. Now you can move your arm around if you want to.
I get frozen shoulder from time to time. So.
Well, doing this
And that's
one.
like the scariest part.
Well, and again, that's subscap.
Yeah.
Like I tell the students, do that one first. And then, of course, the supraspinatus is right up in here, right in there.
Right.
But see, that one directly fights with the subscap.
Right.
So if you get the subscap better, the arm just goes up there. Infraspinatus is the guy down here, and all I want to do is put him in a straight line between here and the infraspinatus, or wherever that tender point is in the
okay.
infraspinatus muscle. And that'll turn these guys off.
Right. I've done that. Yeah,
And then
I've
the
done that.
teres minor is
Yeah.
going to be the one where you just bring it in and, let's see, and it goes this way. Minor is here, then major goes in with the arm behind,
Okay.
and that turns the lower one off.
Cool. That's awesome. Thank you.
Okay? All right.
Treated both AC1s. I've got the left side turf. It was severe, but the right side was worse, and I can't get it off. I was wondering if you could just.
Sure, let's take a look.
I'm a right side from, I was telling you, my knee replacement, my hip, my shoulder, it's all right sided. And I believe in the wrapping.
So this here?
Yeah, that, yeah.
Ah, yeah, okay.
You found it.
Quickly.
So roll him over, like so. How's this now?
Much better.
And then we're going to slide up underneath here. And we
I
bring
didn't
this.
go quite so low as you when I did that earlier.
There we go. How's that now? At least 2/3, yes?
Yes, sir. Hang on. Yes. 2/3. In public school math.
Ah, there we go. Compared to before?
Not existent.
So I just wasn't.
Aggressive enough.
Okay.
You are gentle when I treat you. Some of these old guys are,
Much.
Yeah, you got to put in a little more energy into
My
them.
hand was up here, and I was probably half as far.
Okay, well, you want to make sure you get at least part of the larynx as you bring it across. There, we're getting a pulse now. And it is an MSK point, so again, this is the ones that you're going to spend your 90 seconds on. Or at least until you get a nice therapeutic pulse.
Right.
This is coming.
We did get reduction after the first round of treatment. It just didn't go away. And I didn't want to leave it because it was exquisite.
Yeah. So do you have some TMJ issues?
I
Don't.
Not that I'm aware of. That's painful what you put your finger on.
Right here?
I'd say his face was a punching bag for a lot
Yeah,
of
I
boxing
boxed for a
years.
long time.
So
Oh, so
may
we
not
got
be
some other
known
stuff.
TMJ, but
I've had
just
multiple nerve surgeries from.
but with your face being a punching bag, it makes
Now,
it
is this still tender?
It is not.
Okay. She was on the right path.
Yeah.
You still got that first ribs a little stuck right there.
that one. He had to get his clavicle on that side.
I have a ribbon and a button holding my clavicle in place. A single ribbon.
Okay.
So I mean, it,
That
it
may be
definitely
why it's
went
compensating.
Down. It definitely
Okay.
went down after the treatment.
What I would, oh, it gets so loud here. What I would do is come in across and I check. Yeah, he's got these guys.
Ooh.
So what we do with this is drop your arm on me. There you go.
This is a very similar treatment. Oh, I'm even on the mic.
There you go.
He's right. He's hooking my scapula.
Yeah.
So now my fingertips are on the ribs.
See, it was upper, so it was
Pretty good there now?
Yeah.
Okay. Deep breath for me.
for upper.
Blow it out. Okay, you watch out. Deep breath again. And around. How'd we do?
It's better.
Oh yeah, her fibulas always get stuck. Good.
I don't know, I don't know if I was doing this right here on the top here.
Okay, well let's just have you set it up.
He still had the,
Slide those over there. Good.
he's right, he's sore right
Oh, that's you're on top of the scapula. Where I want to be is right there.
Okay,
Right there.
right in there, okay.
Is that still tender?
Yeah.
Okay, so we'll bring this over. Rest that right on. Nope, keep your hand there.
Oh, okay, all right.
Right there, the wrist rests on your forearm. Now with your forearm and your hand here, we're going to initially pull on the clavicle. Good. And then a little bit on the sternum. We'll let go and then come back. Good. And then we drop it away again. And then go down here and monitor his radial pulse. At that point, this is just all hanging free. Now how does that when you poke you? So
I'm looking to see if it's stronger.
no, all you want to do is look there, but you want to keep the radial pulse alive.
Oh, gotcha. Oh, all right.
And so if it stops, we just do
Oh,
a little of this to make sure that we aren't shutting off the stuff up high.
gotcha, okay. That's why you're doing it.
Yeah.
I thought maybe you were assessing the strength of it or something.
Nothing that exotic.
Okay. All right, okay.
But that should feel pretty good now. Okay? And then you swing the arm across. I like to do it with this hand. Bring this over, let it come down, and then you want to put it away. So you use that. Just you can hold this hand while you do that. Boom, boom. And then you're done. And then go back in and check. So you had it almost there.
So I was looking at the skin. That's kind of stupid. You have it down.
Well, it's the most common thing that happens is when we get up there on top, we don't have enough to. We want to go in front of it, but we think, God, the scalen's not going to be that far forward. So you shove that, but you have to push the trapezius posteriorly. And he tends to roll his shoulders forward a bit.
Yeah, and then
Okay.
with this one,
Uh-huh.
he was a little sore on the right.
Okay. Is it still sore?
The way you treated it earlier was pretty good, but yeah, it's a little sore.
Okay.
And then you just kind of
Just rotate away, yeah. Now if it's still tender a little bit, Then what I want you to do is put a finger in front of the ear and behind the ear, and you're going to pull right towards the top of the head.
Okay.
There we go. And then we poke this and check it now. Gone. There you are.
Okay.
And this one, if it's this, it's only about 30 seconds and you're going to be gone.
Okay. Okay. Yeah. Okay.
All right.
That's good. And then,
Cool.
You had a little bit of a C3 on the right too. That's better though too. I think I released that one.
Yeah, you got the C3 really well.
How about on the left side? Now there you're just looking for congestion or it's stuck.
Yeah. I mean, he's still a little fuller on the right. But left feels pretty good.
Okay. Okay. So at this point, that's when I would have checked the SI joints on either side. Then I find out which one is complaining, and I treat that one, and then I'm done. But that does, for a long time, that's what I would do to treat headaches. And I had really good success.
Wow.
However, when I added this other stuff, the lymphatics, that's when it started going through the roof. Yeah. Yeah.
That's good. Yeah. Good.
It feels thick. But you're in the right spot.
What do I do for Terry's?
Oh, Terry's minor? Okay.
I might have to do more of that.
Well, actually, remember what Terry's minor does? There you go.
Oh yeah, there we go. Thank you.
It's all right.
Yeah, because Terry's major is flexion and then.
Yep, Terry's major is the hammerlock position.
Oh, that's
Terry's
right.
minor is this one. So your Terry's minor, infraspinatus, supraspinatus, they are all this way.
That's right. The major was the.
Yep.
I think he was treating a serratus lymphatic point. So when you find it, do you pull it forward like
Yeah.
that? So that's what he was doing without even knowing. That-
Well,
Based on what I felt.
right. Well, what you'll find here is, all right, if I palpate, you'll find sometimes tender points out in this area above the breast or sometimes more medially.
She had about a T4, T5 rib on this side, and I couldn't release it fully.
And there might be a periternal point there still.
Okay. So a lot of times what you'll find,
There's still a
okay,
periternal point.
so you'll get right in the middle, and this is to be tender, yes? So what I want to do is come over, asking permission,
Right.
and then come over just a bit more lateral to it, and then use just a gentle traction, and that turns it off.
So those are peristernals, they're great for your breastfeeding moms and
So this is going to be just, they go all the way down. Usually they stop at 4 or 5.
Now we're in an era when everybody's on the computer, and I can
Oh, yeah.
just peck trigger points and always get attachment things right.
Uh-huh. Well, if it's there, you can use that traction here.
so you're treating it more MSK, and what he's doing is treating it more lymphatic because he's stretching and you're shortening. Yeah.
Now, I have had some that are post-COVID, and they'll have tender points right along the side here.
Yeah.
And so, again, you can either go away from it, just in the intercostal space, and it's just a gentle fascial glide, and that'll turn that off. Or you can come above it, and then you switch fingers, which one's monitoring, which one's treating, and you go this way. But from the nipple line, most of it goes this way or this way.
Yeah.
But I do have a lot of the gals, though, that come in that have pain in the peristernal area, and it's really sharp. It affects their breathing. It does all kinds of stuff.
And so I'm not familiar with the lymphatic points until Dr. Goering told me about it. It's like that really sharp, very localized pain that's not MSK sore.
Yeah.
It's just like very sharp pinpoint
Stab.
stabby, like ice pick stabby.
And usually along the
Right there. There's these down here or there.
These lymphatic points are anywhere, so he treats like tibial stress syndrome, people that have like IT band, that's very sharp, stabby, and so it's that same principle. All you do is stretch it.
It's a little different than the tender point pain. Now, the tender point pain tends to be more muscular, even though it hurts. But this one, the one that's on your tender point that goes with your lymphatics, it's just like a needle stab.
are you doing the same? And I have to think this newer technique that's at the
Oh, fascial distortion model.
fascial distortion. It almost sounds like some of the stuff they're doing.
Well,
It's different, yeah.
except that what they're doing hands-on prolotherapy.
They're doing hands-on prolotherapy.
Like,
Because they're doing damage. They want to do damage to the tissues to be able to get it to come back and heal itself.
they're trying to distort the fascia or the periosteum or whatever, whereas with this idea, you're stretching the fascia.
We're just
where
letting the
all
body heal itself.
lymphatics are, in order to get that natural pump of the lymphangium. So it's slightly different.
Then there's this other technique I heard about, where they're talking about little, almost fascial herniations, a lot of fat points that go through. And
Yeah, herniated trigger points.
That's them.
That's
that's
FDM.
them?
That's FDM. They have 6 different models, and that's one of them. Trigger band, herniated trigger point, continuous distortion.
This is, I think this works better, and it's a lot kinder for your
the right
patients.
tool for the right.
Easier on your hands, too.
Oh yeah,
Trying to get,
my thumbs are shot. I can't do that.
thank you.
Yes, you're welcome.
And then add that to what we were just doing.
Is he teaching you some new stuff? Good. You have to bring it back to us.
Well, I'm just in Hawaii.
But
I'll come over and teach you. So I do muscle energy all in motion. Because that static hold and release.
yeah,
See how these guys loosed and that guy's still tight. So it'd be interesting to see if adding that, for lack of a better word, the manual tension to this lymphatic would really help. So
yeah, it's cool. We just keep doing them.
she'll just come in here and I'm on it.
Yeah, we probably ought to get going again. Well, we'll go ahead and start talking while we're treating. Okay? All right, so this is a couple of pictures of just where the lymphatics go. One of the things that's kind of interesting is that I took most of these diagrams from some of the people that did fascial massage and lymphatic drainage techniques. The difference is they really don't understand this tractioning thing. And if you can get that down, it really makes all of this happen so much faster. And the thing that I would hopefully in the next little bit we're going to get for you is that you'll get to feel that, what like I call the whoosh, whoosh, and it really follows the cranial rhythm. Well, that's what I think everybody else thinks it's cranial rhythm, and then if we can introduce you to the lymphatics, it's all of a sudden you go, oh, well, this is the same. Yeah. And that's really what I think is, because when we look at the lymphatics that are right in the cranial sutures, if we get all of that stuff activated, then it all comes together. I did get some of this information from Brian Tuckey, who is a physical therapist on the East Coast, and Tim Hodges, massage therapist. Then I've got stuff that I made because I didn't care for what they had. So what we want to look at in the back side, there's going to be the, this one is going to be my posterior inferior what do you call that one?
Cervical.
Yeah. Mm-hmm.
If I pull your table this way, and have you slide? There you go.
Okay. So on the little handout you've got, most of these are already there. So what I do when I'm working with somebody that's got a headache, I start out and I do what we've already done. Then I look around posteriorly and I'll either do this paraspinal. This guy right here is posterior superior cervical thoracic lymphatic tender point. It's really the the ilio. Not the ilio, the one that goes with the thoracic. Oh God, I hate that. A levator scapula. Okay, so you're going to find that levator scap right there. This one in the front is an anterior internal jugular, and we name it just because that's where, if you know that, you know what to do, because you pull the traction over that internal jugular, and the traction for this is just straight up. And then, of course, we're in here. Those are going to be our lymphatic tender point or lymphatic duct or the thoracic duct, and they're going to be enclosed. All right. Okay. This is a picture that has everything. So if you get familiar with this stuff, the way I kind of did that was I would go through and look, is my internal jugular there, is my lymphatic there, is my posterior superior transverse lymphatic tender point, or posterior inferior transverse lymphatic, and this has them all listed out here for you as you go through each one of these guys. And don't spend a lot of time doing it. I mean, you want to just poke them and move on. If it's not there, don't mess with it. Yeah.
Just doing the scanning.
Yep.
And if you feel it,
If you feel it, you treat it. Yeah, you treat what you find, but you do it in this order because you want to make sure that you started as close to the central portion, and then you want to work peripherally. Because if you work peripherally and work your way close to the center, you might get clogged up halfway there. Does that make sense? Okay.
So there's more in this PowerPoint than there on the worksheet. There's about 9 on the worksheet.
Well, you guys will have the PowerPoint now because these pictures are all part of what they're recording. Okay. Another view, this looks at some of the lymphatic flow pattern. So these come down and go in this way. These are coming underneath. This is our inferior cervical transverse, superior cervical transverse. This is going to be my occipital. This is another one. It's a posterior auricular, but it goes right along with these others. So all of these, you're going to traction towards the top of the head. Now, if we want to look at cranial, if I put that person and lay them on their side, their head, and I'm putting traction up this way, and if I do what Jones talked about, and I put a little fulcrum on the other side, I'm really doing a side bending rotation. Okay? So that kind of makes sense through there. And up in here is where we're going to find, there's your anterior auricular. They also call this one mastoid lymphatics because the mastoid lymphatics are there. Then if we're looking for turning this guy off, I want to go all the way over here and I'm going to pull up on this side. There's one that's the submandibular, which is way up here. And with that one, we just reach underneath and just pull your submandibular area. And it's very much like if you did a Galbraith's maneuver. All right. So here's where we're going to start. So these, again, are going to be, all of these are going to be on your film as you bring them back. So first intercostal space, that's going to be this one. That's going to be my lymphatic duct, and I'm going to pull up this way, which then is going to activate the lymphatics that are going to help to bring all of this down into there. Next one, this one tends to be, even for me after doing it for a few years, it tends to make it so that it gets better but not gone, which is frustrating, I know. But if you do this one for about 10 seconds, you start to feel it relax and you'll get the tissue reabsorbed. Then you go down here and you do this one, which is going to be one of your parasternals. And all I'm going to do is traction straight out. And if I do that, this goes away 100%.
So that lower hand is subclavicular?
Yep, subclavicular and the first intercostal space.
Got it.
And that's really fun because that one, you're there. All right, so here should be the internal jugular. It's right on top of the second rib. Usually it's a little bit further out than that, but it's close. And we're just going to pull traction up towards it. So again, most of the stuff that you're going to do early on is going to be just finding that lymphatic point and tractioning away from it. But knowing the anatomy over here allows you to be able to do that. Okay, posterior cervical thoracic, and that's going to be the tender points back here. The tractioning is going to go this way. This is the person that has that levator scap. You're just above levator, but it's that area at the base of the neck. Yeah. Okay. Over here we've got, this is the occipital parotid. This is where that lymphatic tender point is going to be out there in that area. This is the one that's really, really common with headaches. You grab the parotid gland, pull it kind of forward, then up towards the eye, and don't be, disappointed if it takes you a couple times to get it to turn off, because it can. The patients don't always read the book. So this is the motion that we do. This is the area of the tenderness. This is the one that we almost always would end up injecting. At least I did, because I couldn't get this damn thing to turn off and stay turned off. Now, Larry described one, Dr. Jones, as a PC2 that was kind of gets stuck in this area. Some of the literature puts it there, but the PC2 is actually over on the occipital mastoid suture, or it's on the lateral aspect of the spinous process of C2, or on the fascial tissues just right on top of the articular pillar on the transverse process of C2. So it's not back here where most people try and do it. So your submandibular is the one that's just about an inch above where you're going to find your the occipital lymphatic tender point, and it's going to, it's dead. It's going to be just above it. And what we do there is, if you can see when the treatment, you will see where the treatment is. We're just doing, it's similar to a Galbraith maneuver. The fingertips are just under the jaw, traction towards the chin. Oh, okay. Yeah, so we're just tractioning like that. All right. This is the posterior, superior cervical transverse lymphatic tender point. So this is right in here. So the area of tenderness is down on the cervical spine, just below. If you were doing a suboccipital release and you slide your fingers up underneath there, that's where this acute tenderness would be, right in that area here. And we're just going to do a nice little glide across the front of the neck. You're going to go down towards your thoracic duct or the lymphatic duct. All right. So visualizing the area beneath and around the ear for associated tenderness. I can show you if you want the temporal artery. That's kind of fun. When I started doing this, I didn't do any more, I didn't send any more people off to get their temporal artery biopsied. So what I would do in that situation is we use compression on the distal portion of the artery, which causes stretching of the endothelium, which causes relaxation of the musculature, which resets the tenderness, and it's gone. And as soon as the patient understands what it is they need to do, I'm out of work. But that one's there. So the temporal artery, anterior auricular is this one. Be anterior auricular coupled with the posterior auricular, going to be the mastoid, which is here, and that tender point's on the posterior aspect of the ascending ramus of the mandible. And then our AC1 MSK point is here, which is really close. Angle of the jaw, that's another musculoskeletal one, which is tucked up underneath that way. And then our PC1, our PC2, but these are musculoskeletal. So to think about, they have different etiologies. However, if they've got that localized increased sympathetic tone, it's going to cause some issues. All right. So this was the mastoid lymphatic. We showed you this one already. This is a big deal. Again, for people that have nasal congestion or sinuses, this is draining that nasopharyngeal lymphatics, the external auditory meatus, the eustachian tube. And if we blend it with trying to get some of the head moving again better, you're going to take people who have sinus congestion, and they're going to do much better with this.
So do you do the tegrapalatine treatment as well?
No, this is all I need to do.
Really?
Yeah.
Because I found that one's much more effective than stimulating supraorbital.
Yeah.
I've not tried this one, so now I'm going to try that one.
Yeah, this will be fun for you. So this is anterior auricular. Jones did this one in his cranial counterstrain, and I don't think he knew what he was doing, but in his writing, he described the fact that with some tender points, you're going to actually have resorption of fluid, and the edema gets better, and that whole discussion. So that can be what he did. I don't know, other than I do know what it felt like when he did it, and it was just a nice, gentle fascial glide towards the top of the head. Okay, there's a posterior auricular, the same thing. This is the one you see with people who wear glasses, and they get the back side of their glasses set too tight. And because that little bit of pressure is there all the time, you end up with the congestion, and you'll end up with this lymphatic tender point.
Funny, I don't remember, in the course I took with Larry, I don't remember him talking about traction at all.
Right. No, early on, all he ever did was just compress them, shorten it. So this is one that's really, here we've got a tender point that's going to, lymphatic tender point that's going to be between the anterior middle scalene, which you'd think, okay, that should be kind of tender. If you come down and you kind of hook your hand around the coracoid process, what I've got here, and then I traction away from it, and that's where that subclavian tender point OB. Yeah, this one I don't find all the time, but boy, if somebody's had a COVID or their COVID vaccination was out there in this arm, down in here, absolutely that's going to be there. Because all of those what's that? All the lymphatic stuff is going to come back and drain through all those nodes in this area, and you really need to be able to activate them to get them going. Now, if you look right along here, there's little lymph nodes going right there in all those intercostal spaces, and those are parasternal. Jones found those, and he would call them interspaces. Now, he treated them with complete shorten. But he found the points. Now, what we do know is that if I can come in here and I find that point and I just traction away, now the arrows are the direction of the flow. You can pull them towards or away. All we need to do is stretch that vessel. This is an earlier picture, but most of the time what I'll find with these guys, I'll traction this way, towards the breast. Now everything nipple line medially goes through the parasternals, nipple line laterally goes around through the axilla. Oftentimes you'll find that there isn't a whole lot of congestion here, but it'll all be up in here. And once you get this to release, then everything takes off and you're done. Yes?
How about your women with breast cancer and all sorts of, lymph node dissection, even if it was minor and they were just doing testing or they would pull a whole chain? What do you see? And that's skin cancer folks.
What I have is a nice discussion with my patient, and I tell them about the fact that they've got this cancer, and they know they've got the cancer there by the time they get to me, most of the time. And I tell them that the medication that they're going to get has to get to the cancer.
Oh, no, I'm talking about
Post-surgical lymphadenopathy.
Oh, then I treat them just like this.
Lymphedema.
Now one of the things that's really cool about lymphatics, and I learned this as a veterinarian, because we would do a lot of kind of bold surgeries and put it back together. The animals that kept moving, the lymphatics grew back. The animals that sat around and did nothing, their leg just get bigger and bigger and bigger. So one of the things that I always do with patients after they've got everything done, I want them to be as active as they can. I'll come in here and I'll stretch these guys. And it may be that the lymphatic vessels are going to grow around this way, but they will regrow themselves. That's been documented. That works. That would probably work as well. But I want to make sure now if they did a surgery across here, I want to be making sure that the posterior axillary is going to be opened up, because that's where all that fluid is going to come around this way. If it's down in here, we're going to have to make sure we get on either side of it and keep it going. A lot of times you're going to have patients that have anterior chest pain here. The first gal I went to try and treat those, she slapped my hand and said, "Don't do that, it hurts." And I said, "Really?" She said, "Everybody hurts there." And I said, "Really?" So I convinced her that I should be able to treat it. And I did, and all I did was just this simple thing. I told her and taught her how to do it for herself, this way and this way. She came back the next time to see me, and she had the biggest grin on her face, and she said, "It doesn't have to hurt, does it?" So I think a lot of times there's a whole bunch of suppositions you can make. Is it because we put the women in brassieres and we make it so that their breasts don't have normal motion that results in the encouragement of the lymphatic flow? I don't know. My job is to treat them. Okay. This is the levator scap one. And if you look back here, and everybody has found this one in their patients. It's that place where you come back on top of the levator scap and there's just this knot that's back there, or a lump. And everybody calls it a trapezius. Well, not everybody, but trapezius is what it usually is diagnosed as. I don't think I've treated a trapezius in 20 years. It's a big muscle. One of the things that we know now is that the spindle concentration in the little muscles, if we look at the paraspinal muscles, you're going to find anywhere from 400 plus spindles per gram. If I look at the trapezius, it's 40 to 50. Latissimus, same sort of thing. Quads, same thing. So those guys are big muscle big muscles, but they are pretty stupid because they don't have the sense that the spindle does. So if you find the little muscles, like the piriformis compared to all the other muscles in the leg, piriformis is pretty important because it's running the show. So that's the same thing in here. Now here what we've got is we've got all of these guys get congested because something's going on right there at the base of the neck. All right, there's the peristernal lymphatics that we talked about. This posterior circumflex, this is one that I don't really have a good picture for. So let's see. Who wants to be my victim? Okay, come on over. Whoever. Lie down on the table there.
Should I be as fearful of it as I was before?
Oh, yeah.
Okay.
So we come up underneath, and I want to poke right. Oh, you do. Is this a little tender here?
Mm-hmm.
Okay, can I have your right hand, please? So what I want to do is bring this up, and here's my spot, right in here. And now I just traction. And this is pretty good. You just lean back with it. How are we doing?
Mm.
Good?
Mm.
Okay.
Mm-hmm.
So
It is alive.
it's just all traction, and this is pulling through. So this would be draining the whole breast if we have where we got dissections through that area. Okay. Now, the other ones that are kind of hard to see, you can set this down now, thank you, is if we have come up here and we've got that subclavian that's going to be right down in here, I would come in on top, and it's going to be right on top. And of course, everybody says, well, sure, it's got the brachial plexus there, it hurts.
Where are you?
Right where the brachial plexus be, right between the anterior and middle scaling. You grab the coracoid process and just roll it over, and that's it. Once this gets draining, and you can pull it this way too if you, but this is, once that gets draining, it's going to activate and pull this out of the whole top of the breast into the anterior axilla. All of this is going to come up. It's going to get underneath because we're deep enough. We're going to be underneath and through the pec so that that area is going to get tractioned as well. Yeah, you're turning on good.
Mm-hmm.
Can you talk to the group? What does turning off mean to you?
Lack of motion. It just feels kind of dead. What he's doing now, he's got this push, push. Not quite a pulse because that's more of a thump, thump. This is just a wave.
Do all the lymphatics follow the pulsatile pressure of the other vessels?
Not really, because they're going to be independent. That's one of the things that's really, they fit much more into line with if you were going to feel for a cranial pulse.
Okay.
So 10 to 12 per minute versus 50 to 60.
Yes, sir.
Can we just show the ones on the worksheet? Is that how you?
Sure, we can do either way. We kind of got off track here, so. Oh, there we go. All right, so let's see. Why don't you just call out?
The old-fashioned lymphatic pump university.
We do at the university, but the thing that I found with the old-fashioned lymphatic pump, the data shows even when we do this one.
Well, I'm even just, this
Yeah, that one. It works as long as you do it. As soon as you stop, it stops,
Okay.
which is really sucks because it does help. I think it's probably more helpful for the people that have, respiratory issues. Your guys that have, COPD and that sort of thing, as long as you don't do the activating component where you let them come up quick.
Well, that's my favorite part.
Well, that come up quick on the COPD guys just fills them up with air again, and they can't move it. You got to keep them empty. Well, I understand now what you're saying. Okay. All right. So this is our subclavian. This is the levator scap one. I think you guys are going to do this one more than some of the others. So I don't know if you've really got much in there. Oh, you do on this side.
Mm-hmm.
You're right there.
Yeah, the left side's jealous.
Okay. So.
The right side's gonna get all the love.
So his isn't really bad, but it's there. So you want to come in and feel this just once. You might want to just mash in there.
Ow.
Oh, yeah.
And he's going to ow for you.
Felt my
So
share
just
of-
between the like I said, his isn't real bad, but
Right there.
So back in here?
it's going to be just right on the top, right where your levator scap would be, right there.
Okay.
Mind if we all come along and push as hard as we can, Rob?
Go for it. Yeah, get back.
Up in there.
Get back and wait for all the torch I put you guys through.
Yeah, right there. So what we do is we just,
Brought in the yoga in the morning, so that's okay.
oh, yeah.
Glad you enjoyed it.
Yeah, it's going to be right in this area right there. Right in that corner of
That
the,
guy?
Yeah. Dr. Schultz, you can sit down and monitor too if you want.
what we're going to do now is like bring this up and traction. You see, the traction should be right through where that bubble is, or essentially that lymphedema. Yeah, it's starting to go.
It just falls away.
Uh-huh. And so what's happening, and they've got places where they've injected people with dye, and then if you do this, you can just see where it sucks it up and moves it through.
Don't forget to put lidocaine in that dye. Super painful.
This next week, we're going to start a project working on some rats in myofascial release. Of course, I think it's going to be lymphatic treatment that they're doing. But what they're going to do is mimic the blunt force trauma on the hamstring. So they're going to stab these little rats, and then they're going to treat them. And we're going to do MFR, but it'll be mostly lymphatic type stuff. And we're going to see if that heals faster than it does with nothing. Ah, there it goes. I'm going to let him go now. But you see, you got that kind of a whoosh. And it comes back. It's a much different kind of a thing than it is your pulse. Mm-hmm.
More wave-like.
Yeah. It's more like, yeah, a glide. Dr. Starts with a B.
Blummer?
No. No.
That's right, we'll figure it
The
out.
physiologist. Dr. McCulley, not a B, an M. Belinda. The first name was a B. Yes. All right. Okay, so that one we're done. This is the one we did that we talked about the breast already. And that's the posterior circumflex humeral lymphatic. This is one that's kind of fun.
These are the ones that are on the
That's what we
worksheet
were talking about
too.
earlier, I think.
Okay, we haven't done this one.
Thoracic duct, internal jugular, and paraspinal.
We did those.
We haven't done these.
What's that? Okay, that's fine. But these guys might have opportunity to see these, because if you've got somebody who has a distal humeral fracture, one of the big concerns we always talk about is, did it cut the artery? And if it did, or the nerve. So what we end up with is pain and or dysfunction clear out into the extremity. If it's the artery, this was again a patient that came to me that said, I broke my arm, and ever since they fixed it, it just hurt like hell. That was, quote unquote, the comment. So the pain you'll get is this guy right up along the side of the distal humerus. You got not much there. So you come in here and you get below it, and with the arteries, you want to plug it, essentially, and as you cause back pressure, you're going to stretch the endothelium. And so what I'm looking for is a nice little pulse in there. He's not even alive. There it goes. And once you get the pulse, then you hold it for a count of 10 or so. Because now the pulse is boom, 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 which is different than the wave. And then you come back and recheck. And I only treat these guys once or twice, and they're done. The other one that's really fun is the pronator, which is going to be right in the pronator muscle. Anything in there? No. You'll get those guys that are typing all the time, and they're in there. What we do at that point, we get this point, then just fascial glide right down the middle. Turns it right off. Now, Jones counterstrain, you would bring them around like so and treat that, but okay, Pronator. Oh, it is in the pictures. Okay. So the tender point is right in here. Remember with the guys that get carpal tunnel syndrome? This is again a quote from Dr. Jones. More than half of them are going to have radial head dysfunction. Okay. So again, radial head, you come in here and you treat with extension, external rotation. Okay, once that's done and you've shook hands with them and you've got this is our treatment for that radial head, then a thing I've added is I come up and we grab the radius and we float it and just lift it up. And this one takes probably more time than anything else, but if you can do that, that balances that interosseous ligament, which then allows the function to return and your pain is substantially less. Now, as I've said that, and I work my way through, no, we're looking at the hand now. If you look at the hand, right down there, you're going to find folks that still have tenderness in their carpal tunnel area, right in here. So what do we do with that? We come in, now this is not doing counter strain, but this is the lymphatic, so we just do a little traction and we pull through the vessel and that'll release it. And
Sutter hasn't taught for us in a long time. You know Ben Sutter?
I've heard the name, yes.
He has a manipulation technique he loves to teach on that one.
So there's that. And then you can do the other side for the canal of Guillain, because that one will be there. Yeah. That was just a picture to show you where all of the guys are that should be cleared when you go through and you treat somebody. So you get 22 points to evaluate, your MSK, you do those, then you come down and you do lymphatic thoracics, and you work your way through those. And they're all in the stuff that we've got here. So you work your way through them, and you're going to have some really amazing results. It's really fun.
Do you want to show the 8 on here, or let them play?
Well, let's go through them real quick. And so I'll let you find them.
I will put them back on here for you.
Somebody's boot's getting squished. There you go. Okay. So she's going to test me now, see? All right, so this is going to be our thoracic duct or lymphatic duct, or the other one it's going to be is the parasternal. So can I open this up just a bit? Mm-hmm. So right in here, here's your clavicle, right on that inside edge, that's the one we call a lymphatic duct because it's on the right side. So to drain this one, you come up above the clavicle and go down, and we just traction up towards the head. Now don't push too hard or you'll get the carotid, and we don't want to squish the carotid. And this will be at least 50% better once we're here. I don't think he had it to start with, so I'm just kind of walking through it. Now 50%, 70%, a lot of times you'd say, oh, that's good enough, that's my 2/3. So we let go of that. Then we come over and we do the parasternal version. We slide my fingers down and we use traction straight away, and that'll be 100% gone. So this is the right side, so it's lymphatic duct. It's not the left side, because the left side we call it the thoracic duct, just because of that's what we do. All right. Next one is going to be the internal jugular. It's going to be on the second rib, just about there. No, yes, no.
You're pushing directly down, correct?
Yeah, right down on top of it. There's a Chapman's point here, and I always forget what it is. But I should know that one, because there is a Chapman's point that's right on top, and I can't remember whether it's occipital or something like, or eye or something. So now what I want to do is come up, and on that, because it's internal jugular, I want to just go right along where the internal jugular would be, and I'm just going to glide even with it. And then that should turn off. Not that he had it, but that's what you do. Okay? And these are kind of fun to play with your spouse, because a lot of times people will have these tender points, these lymphatic points, and they don't know it. But once you get them treated, then they feel so much better, because all of that used up fluid is left behind. Oh, you got a nice wave going here. And this is a whoosh, whoosh, Yeah. Then if we do the posterior cervical, transverse cervical lymphatic tender points, those guys are going to be back here, right in this area. Oh, right there. Oh, he's got some. Right underneath. And we'll take this one, and we're going to just kind of pull it. We saw the lymphatics, so what we want to do here is just pull towards where I want it to go. And that's gone. And it isn't violent traction, it's just a nice little gentle glide. If you pull too hard, you're going to stretch the lymphatic vessels, and they're going to say, I'm not going to do it. So you have to treat it. There it goes. Good.
A lot of students might say skin level, so you want to make sure you're down to the fascial level before you traction. So sink down to that fascia and then get your traction.
There we go. And it's gone. So they should go that quickly.
There's a posterior superior too.
Yeah, that other one comes up here. And for that one, we're going to, again, we're draining down into this way, so we're going to come in here. Now, you'll find that some of your others that you'll pick up, now I'm going like this, just because it's more comfortable for my hand.
Students were calling it the C7 necklace because you kind of come across like a necklace.
There it goes. Now you'll get a pulse, which he's got boom, 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 boom. And that's different than the wave. All right. Much better.
This is the moneymaker.
Oh yeah, this is the moneymaker. So if we're right here in the back of the skull, and we come right up underneath here, and there's this guy right there. Okay, right in the back of the head. And that one, we just grab that cheek.
So he's just palpating right where the occipital nerve comes.
Right, you'll just find where the nerve comes through. When it's swollen or dysfunctional, it'll feel doughy, and it'll even feel kind of firm. Once you do this little maneuver where you grab the cheek and roll the nose up towards the eye, and you give it just a little bit to take off, then it feels like a divot, and the pain's gone, or the tenderness is gone.
Where do you feel the divot, in the cheek or in the back?
Right here.
Okay.
Because what's happened where that nerve, the nerve artery vein lymphatic comes through a little canal back there, and that's where you get the congestion because you shut down the lymphatics, they swell up, you got the lymphedema, that pushes on the nerve, and when you palpate this guy, I mean, it's done now. I just get bored. It's there.
What's a good long-term treatment on that? Like if I have a patient with a fusion, cervical fusion back there, that really is totally the pattern.
So sit here, they can reach up over the top and do this. I've got students from 2 different years that went through and actually created, and I didn't get them put together, created self-treatment plans. So they can go through almost all of these and do it themselves.
Could you do any of that with therapeutic taping?
I've tried that. I had one of my, Dr. Turner, she was there with us on our cranial stuff. But Dr. Turner, she had a hell of a problem with her leg, and she has experimented with doing some taping. She had a compartment syndrome on her leg, and it just wiped her out. So now she does some taping on her foot across the top, this crisscross over the top, and that helps.
Okay, so it does help.
Does help.
I've also tried it. I'm thinking of extrapolating that to PDO threads.
Yeah, yeah.
If the taping works, then maybe do a PDO thread in there.
Yeah. So that was there. Submandibular, if you're looking at this guy here, that's where we just did. We would be up just above it.
Okay.
And that one we just reach underneath the jaw and just grab and pull out towards the chin. Just that. So it isn't as aggressive as a Galbraith. It's just slide up underneath here and do this. I often wonder if the Galbraith that we're doing is probably more aggressive than we need.
How did you come up with the, when you're treating the greater occipital nerve area?
Oh, this one?
Around versus just going with the flow towards the thoracic duct?
That was one I was introduced to by the PT friends.
Okay.
And again, what they did was they said, well, we think it's this. And now we've gone back and you look at the, where they've actually done some injections in the top of the head to see where the lymphatics flow. And they come this way together. Yeah. And so what we're really probably doing is activating the lymphatics down below. And once they start pumping, you get the fluid moving past that valve. That's the trick. And it doesn't really matter how you do that. You can go upstream or downstream, but once you get that going, as long as there's fluid to get pulled in, as it passes the valve, it's going to activate that.
It would seem to be a tactile thing.
Oh, yeah.
Go whichever, as long as you're feeling the result.
Now, Ann Habeneck used to do a bunch. Judy O'Connor in the Midwest, they do a bunch. She does myofascial release, but what she's doing is this. She's just doing it without calling it what this other part. So I think a lot of times you'll find somebody who's a massage therapist that's really, really good, and it's because they've learned, just because they put their hands on so many bodies, that if I do this, this is what's going to happen. If I do this, this is what's going to happen. And what we've tried to do here is come back and say, scientifically, this is what we're doing. And I guarantee you that if you get somebody with a nasty headache, you can treat them out in 15, 20 minutes and then you teach them how to do it themselves, or you can get them to have and if somebody wants a copy of that, send me your information, and I will try and get a copy of the, Rob Elder, who is now a practicing physician in the Eugene area, has one for both patients, because descriptors for a patient versus descriptors for a physician are a little different. So he has a handout that you can give to your patient versus one you can walk them through it with it. And I can send those to you on an email.
The one that's not in the PowerPoint, the glabella one?
Oh, yeah.
Lymphatics.
Yeah, the lymphatics. That's one that just kind of, I did a lot, but now I understand why it works. When you're working with somebody, remember how as your sphenoid rocks back and forth, the vomer goes down, which causes that other motion. Your glabella, you can monitor your cranial pulse right here. And so now you can just start pushing on it, and that works. You can sometimes get lymphatic tender points here. Now, what I do is put my arm here. The tenderness is going to be either on the medial or lateral canthus, supraorbital nerve, but your arm is resting right on the forehead, and then the meaty part of your arm just kind of slides.
It's pulling on that frontal temporal fascia.
All of
away
this.
From the lymphatics.
And this one maybe take you 15, 20 minutes to slide off the top of their head, and that's kind of what you're
You
doing.
have to follow up with suture release then if you're pushing.
I don't.
Jam those sutures together.
I don't.
Above your arm.
Well, the only thing I'd be getting is the coronal sutures up there, but we got the metopic suture that's here, and all we're really worrying about is we need to make it more flexible. But they can do that. You can also come out laterally. There are some lateral canthus. Now, Jones talks about the lateral zygomatic tender points, and the treatment essentially is for him is compression. I've discovered that if I just do a little bit of traction, which is kind of like when they get facials, it releases the same thing. So the Chinese for a long time have done a lot of acupuncture and stuff. In reality, they tried to come up with why it works. We still don't know why it works, but we do know that if you stick a needle in this spot, this is what's going to happen. Some of this is probably okay. I think, though, what I want to do is try and learn why what I do does what it does. And so that's kind of my message with this lymphatic stuff. The first course I got, or the first information I got was kind of like this. It was this many people. I got this much information, went home and started playing with it, and it was so successful I just couldn't keep it to myself. I had to build it, and then when I got to the school, I wanted to share it because I would treat students that had these horrible headaches, and they'd say, "So what are you really doing?" And so it all turned into this kind of a thing. Eventually, we'll let the students help me, and we'll make a book out of it and make it available, but that's... So any other questions? If it's turn, John, so you can try and do these. Oh, I should do one other thing, though, because you guys work with feet and neuropathy a lot. Does anybody have any foot problems, neuropathy, feet pain, tenderness? Yes?
Yes.
Okay, get that. You can slip your sock off on the side you want me to treat.
He carries
Damage here.
40-pound packs on his back.
All right, rest your leg right up here.
Well, kickboxing.
Kickball, okay.
People in the 80s used to use their elbows to block. So so I destroyed the nerve across the top here.
It's tender up there.
It's tender here, very tender.
Uh-huh.
And,
How about in here? Well, I'd say that's pretty tender right there.
pretty tender.
So what we find, and how about up here?
Mildly so.
Oh, you have a whole bunch. Oh, I'm sorry. I got off the table. So shin splints are here. Don't have much of that. Okay, those are, we can treat shin splints. Again, 10, 15 minutes, not minutes, 10, 15 seconds, it's gone. But this one, right in here, okay, so this would be your medial ankle tender point with counter strain. If we have stuff over here underneath that tarsal ligament, that would be more lymphatic. He doesn't have that one. And then the next one I go after, and this is really, really common, post-chemo. And they have this tenderness that's going to be right in here, and they talk to you about how their foot hurts, or so we put a thumb on top, finger on the bottom, and I just do a little twist. How's that now?
Better. I angered it last year when I did Nijmegen Rock March, which is in Holland. It's 4 25s in a row with a little bit of beer. It's one of the better ones to do. It's the world's largest foot march. 60,000 people do it every year, and only 8,000 military. So it's mainly civilians. Wow. Where is it? In Holland and Nijmegen,
What time of year?
Netherlands. June.
Are we stomping tulips or grapes or both?
You just
So this doesn't,
take it off for 25 miles.
We're okay.
It's actually a huge.
we're okay with this one now?
Yeah.
So then we come up to the next one. Yeah,
Yeah, that's
You're going into digital, I mean,
right.
between the metatarsal.
Uh-huh. And that should be gone.
So you can apply the principles anywhere, essentially, is what Dr. Goering is mentioning. And as long as you're finding the tender point, stretching it, a lot of them are going to be along with those superficial sensory nerves where they exit. And if a lot of people get them along the IT band, and as long
That's
as you
pretty
find
much
that
gone.
spot where that superficial
Here we
sensory
get
nerve
this one.
pierces and
Ooh,
stretch
hi.
away, stretching
That's
lymph
the one that
ganglia,
broke.
then that's the principle.
I had a shattered fracture on the
Uh-huh.
fourth toe. Another
How's,
karate accident.
how's this now?
Better. Yeah, it's a great rock march. They line the thing with food and beer, and you just basically, and for the Dutch, it's black salted licorice and cucumber slices. Not sure why, but
Why is it in Holland?
because they started it 100,
Oh.
100 years ago. And you get a little nice medal for it and all that, and then they change the medal every time you do it to show how
Keep
much.
you coming back.
I was walking with a guy who was like 75. He'd been doing it 50-some years. And after a while, he's just like, yeah, it's been great chatting with you. You know, you came from Hawaii. That's awesome, but I got to go. It just sped past me like I was standing still. We were doing a good clip. And I was like, okay. The Europeans hike. That's their thing, is they rock.
Right here?
Yeah, that's all tender.
So again,
425?
Yeah, 425. Yeah, you get up at like 4:35 to get rolling because of the heat. I was probably the only one acclimated to the heat, so
how's that now?
that's good. And then on the fourth day at about mile 12, I started to get a little foot drop.
Oh.
And I think it was due to anterior
boot.
tibia just
Oh.
failing, and then I just crushed that nerve even worse, so. I was more worried about compartment syndrome, so.
Do you get a baby sheep or anything like that then?
No, you get a little tiny medal and the right to say, I did Nijmegen, which was kind of
You
fun.
said there was baby sheep.
Oh, you gotta,
It's also the world's
So
largest
we can go
open
to the
music
tables
festival.
too for people.
okay.
Open music festival. It's the largest in the world. They have like 5 stages. And people stay up at night dancing. All.
So is this one tender?
Yeah, but it's very.
When is it?
I believe in June. June or July. I think it's June.
So this is the navicular that we would treat. Now you can do the HVLA version, but I think that probably would just run into a block with him. So I'm going to push down on the top.
Experience there.
How's that now?
That's way better. It's
So
not painful at all.
I do it differently than Dr. Jones did it. Dr. Jones would wrap his fingers around and he would roll that sucker over. I never could get that to happen, and when my thumbs got to where they were pretty well shot, they couldn't do that either. So now what I do is grab a hold of the top of the navicular, push it through, and then I grab the navicular tuberosity and roll it. And then that turns the guy off pretty much.
Yeah.
So when you do this for your patients, especially if you do it for some of the ladies that have had chemo, the first one looked at me and she said, I can't feel my foot. I can't feel my foot. And I thought, holy cow, what did I do? Yeah. I grabbed her foot and I said, you can feel this? She said, oh, I can feel that. Oh, well, you just don't have the pain anymore. And so if the pain goes away, then now the one that I'm doing right now is a 90-second hold guy. This is because we're inverting his navicular, which is the old Jones way of doing it, and we wait for the rest of the tissues to relax so that it'll go back where it belongs instead of where it was. Yeah, that's much better.
Yeah.
It's time to go rough and screw it up again.
Yeah.
So what do you think?
Yeah, definitely less tender. Because normally if I touch here, it's just, I swear.
So you get the edema. The lymphedema is right at the bifurcation between the two metatarsals. And what will happen, they'll get lymphedema here, and as soon as that's there, then it pushes on the nerves. And every time they walk, ouch, 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 unless they're tough and foolish like this guy here.
Foolish, not tough. Oh. That was my 60th birthday present.
We really want to thank both of you for being a part of the conference and coming up for it.
This is really.
The students came along and
Yeah,
we had a
that's-
great student session yesterday.
Oh yeah, that was amazing. There must have been 50, 60 people in there, students. So
you rarely do the 90-second Jones
We got a 4-hour drive.
actually, I do that most because that's what we did first. Remember those first 3 or 4 points? I did first rib, and then what's complication with that? C3, C1. You got to clear that out because if you get rid of that, you're reducing then the amount of sympathetic tone that's going to come back and recreate this other. That's why with this one, if we do the navicular, that's going to reduce the chronic and that is what increases the potential for his interosseous guys to come back.
Yeah.
So.
You're treating until you feel the release, until you feel it soften.
Oh yeah.
You're not doing.
Oh, 90?
Larry said it was 90.
Now, what he would do with the 90 seconds, let's be real honest with him, he would say you hold it for 90 seconds to get the most consistent results for the beginner.
Oh, I missed the beginner part.
So
I remember him saying you get better results holding it longer.
right. So if you feel confident and you get pretty good with this, 60 seconds usually is it. Now, what else takes about 60 seconds to release? If you look at Travell's work, and Travell and Simon, you put a gentle traction on that trigger point, which is a spasm muscle. If you hold it about 60 seconds, is what the literature says in Travell's book, hold it about 60 seconds, you'll feel a softening and release of the tissues. So it's like, oh.
Procaine and other things.
Spray stretch.
Right. Well, I just do the 60 seconds. And the thing is, if you do the 60 seconds, you've got a trigger over here. Look at the antagonist for the tender point, because it'll always be there. And if you find your tender point, you pull it up till you get that turned off, then the other will go away because you're turning off the primary source of the dysfunction, which is the tender point.
Yeah.
It's that inappropriately tight muscle.
In most cases, though, can you usually apply a compression or distraction to kind of speed up the process?
I don't think so. My experience has been if I do that, sometimes I get lucky and it works. But the problem with that when I'm with patients, if I'm trying that, then I know I'm gambling with what's going to happen the next session. Okay. And I want to make sure that maybe if it's 5 o'clock and I want to try and see if I can speed it up, then I'll do that. But if it's 8 in the morning, I don't want to carry that mistake through the whole day.
For the students, we teach fine tuning as well now. So it's not just hold that exact position.
Oh,
but
yeah.
You might want to micro tune a little bit.
Yeah, you're going to follow it as it starts to release. And Larry had some, it's hard because I'm going through the book now, line by line by line. He talked about the fact that there probably is some resorption of fluid, some edema, and everything like that was present in some of the lymphatic or some of the tender points that you would find. So he was already starting to recognize that there most likely was something else involved besides just the muscular component. So, but he didn't know what it was, and it makes sense. We really didn't see lymphatics until probably early 2000, where we actually looked at the vessels. That one thing that I was showing you that showed the pumping of the vessels, that's a 2008, I think. And so this lymphatic stuff has only been around with us for maybe 17 years now. It's new stuff, brand new, and I think as we go along and we treat more, we're going to find that it is going to have more impact.
It wasn't only like 6 years ago or something when the fascia, quote unquote, was discovered.
Oh yeah.
Interstitium,
Yeah.
yeah.
And like we've been doing it forever, but you know, a lot of the lymphatic things you're going, if you look at the gallbladder.
Oh yeah.
And the
It
lymphatics.
follows the gallbladder very closely.
Well, that's one of the other things that I have done that I haven't talked about much, but is visceral counterstrain. And one of the things that I'll do is
I need some training up on that.
I went back and I looked at what because there was a group of guys that were overdoing visceral manipulation and looking for visceral somatic responses. And I didn't want to just do the muscular component. I wanted to look at the viscera as well, because you got to treat viscera. And I found that I looked at what Baral was
Just gotta get my luggage down.
what Baral was doing. And if we look at what Baral's doing, and then you, like the liver, he talks about the liver. It's a rib angle on the 5th or 6th rib on the right side. And you go back there, and it's a stubborn rib that you can't get to treat out, and it doesn't get better. You get them in the right position for resting, which is what I would do for a musculoskeletal, but it just doesn't get better because you got the linkage that's going from the vertebrae out to the rib, and it just stays there. But if you put your hand over the inferior aspect of the liver and you glide it a little bit medially or laterally, because it goes one of the two ways, and the darn thing just releases, the rib goes away, it just slides in, you get a pulse underneath. So what we're doing is we're treating your visceral component, which has a manifestation, and the distal portion. So,
Does anybody have reflux?
oh yeah, the reflux one is really fun, because it's on the left
Do
side.
you have reflux at all? Chronic?
Oh.
You lay on the table, he'll treat the reflux on that chronic.
Oh, it's kind of fun, yeah.
You got a hip issue too?
Oh, excuse me.
The students are just checking out. Do you have to check out of the room, or is
Yeah, I do.
Barbu's gonna?
Yeah, I'll do it. I'll go up. And what time is it? Well, they check out as 12, isn't it?
12.
Yeah. Well, this will be my last one.
Okay.
What side? What
Well, I
side?
can barely walk, this is my left, yeah.
Yeah. Nice working with you.
So if we're looking at this, we go up underneath here, and if he's got oh yeah, just relax. I'm not going to
I
hurt
do
you
this
very
one on my
much.
patient. It's that
Right here?
left-sided
And
5,
here?
6 region.
There we go.
That always comes back after you treat them.
It's right here. You're a little
Yeah,
too
5,
low.
6.
A little higher up, where my middle finger is. Yeah, it's right there.
But it always comes back. It's like, it's always coming back. Like a week
Yeah, right
later,
there.
2 weeks later, and then he just tractions the.
So we do this, we rest this over, and then we reach down inside of here and get your,
It's also good for people with minor hiatal hernia.
yeah, oh yeah.
1 to 2 millimeter
And so we do a little tug on his,
or centimeter.
and sometimes they can feel the traction
Doing a traction.
towards his feet. Oh yeah, how's that now?
Better.
And so what we're doing is just getting that to release. It's fun. There goes the pulse. You'll have a pulse as the release occurs in the back. And that way you know where you're supposed to be, because this is a somatic dysfunction that goes with a visceral problem.
Every once in a while, I get like
Just slide right underneath
flare
there.
up of like ileocecal
My middle finger,
region,
right in there.
and he'll monitor the back
Right there.
and twist on that ileocecal region. to kind of
Well, it
treat
comes
the
right out to the rib.
That's great, yeah, wow.
And so if I have somebody that has
with reflux.
too much problem, we'll teach a family member how to help him. But then we also have to have the discussion about eating too late at night. This is almost always my medical students, eating too late at night, gone to the Mexican food and coffee and all the stuff we tell them. And I do think that you should probably go on omeprazole for, 4 to 6 weeks. That helps my process faster, speeds it up. And then when you go off of that, you have to continue to behave. Yeah. Pretty much gone, yeah? So take a deep breath for me.
So are you treating, I know you're
One
releasing,
more.
Are you also treating the diaphragm?
Deep breath.
Releasing the
Not
cranial
really.
diaphragm?
It probably has some effect to that over there as well. The diaphragm, the tender point, or the thing you're going to get up here on the crura, is going to be that abdominal second lumbar that Jones talks about, and you dive down in here, and that's what that one is. The other psoas you get is going to be down lower in this area, and that one there's a new way to treat that one. We'll see if he's got this thing. So he pulled a hamstring, huh?
Yeah, on the left.
On this side, yeah. So you probably had this too.
So that's the causing pain.
Okay. Oh, just rest that right on me. Good. So if you try and help me, it'll hurt you.
Okay, all
Let's
right.
bring this one up too. Put it on top. There we go. Now, what he would do is pull it, towards you in this way, but we found that it's still there some, yeah?
It's better though.
Yeah, but not gone. So if we do this, what we got now, I'm just going to lean back away, and we're going to just do a pelvic tilt.
So the traction I love.
Yeah, it's just
A little bit of traction, bringing the sacrum up by using a fulcrum on the feet, that helps quite a bit to release that.
And I used to think that their calves would hurt too much, but we'll find here that with this gone, his hamstring isn't going to hurt nearly as much.
How long has Jones been gone?
80, he died at 83. He received the big award in 96, 97. He got the Medallion of Honor finally, and then a month later he died.
Oh, wow.
So at least he got to have some recognition there. We got a nice pulse in here.
So Dr. Goering teaches internationally through the Jones Institute.
Well, and we did the OIP thing, which was kind of fun, going to London, teaching them about Jones and counterstrain. It's interesting, that that game that you play with called telegraph or something, where you tell something to the next person, and how much it changes between the beginning and the end. Yeah. How's that now?
Much better.
Okay, no, don't help me. All right, bring this down, let him slide down. Okay, now you can get up and see what you think, because I think your hamstring's going to be much better.
Yeah, it is. It's much better.
So one of my favorite test questions, especially when we have somebody interviewing to become a fellow, I'll ask them, what makes tight heel cords? What makes tight hamstrings? Tight hip flexors. If you take away the tight hip flexors, all the rest of it will balance out, almost always.
And vice versa.
Yeah. But well, this guy here is with the students. They're always sitting, everybody's sitting, and we do that too. I mean, we're sitting and writing and doing everything. We go to stand up. The part that gets stretched is here, but it's chronically pulling us forward. So this is where our tender points are, and this is where our trigger points are. Trigger points hurt us. Tender points don't until you poke them. So
You have an easy stretch for these guys?
Jones would do a thing that was like sitting, and I don't know if the term is correct anymore, sitting Indian style on the floor, where you do crisscross, and then you sit with two chairs on either side and then fall forward as far as you possibly can. And you stay there for 90 seconds or whatever. Usually more than 90 seconds isn't going to give you any benefit. That's the kicker there. So, and then at that point, what you do is you push yourself up with your hands. And that'll get you about the best stretch that I know, or shortening, that you can do by yourself. I've got some students that can fold themselves in half. And I just tell them, great, do that. That's what you do. But that's pretty much it.